Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. Dear colleagues, respected seniors, and our esteemed guest of honor, good morning and Assalamu alaikum. Let's begin this event with the recitation of Holy Quran.
Bismillahirrahmanirrahim.
Subhanallah. The Colorectal Disease Patient Welfare Association and the organizing committee welcome you to the pre-conference Laparoscopic Hands-on Workshop 2022. I am Dr. Mahrukh Akhtar, surgical resident at Colorectal Unit in Civil Hospital. Ladies and gentlemen, colorectal cancer is currently the second most commonly diagnosed malignancy worldwide in both men and women. Screening, early detection, and prompt treatment are the cornerstones of managing colorectal cancers. Colorectal Cancer Disease Patient Welfare Association is playing a crucial role in this regard. It has the honor of generating funds, running a dedicated OPD and a colorectal unit in a public sector hospital. To formally begin with this event, I would like to call on stage Professor Mujib Abbasi, Chairman Colorectal Disease Patient Welfare Association. He is a renowned general surgeon specialized in the field of colorectal diseases. He has played a pivotal role in bringing back COLOCON after a period of 2 years due to coronavirus pandemic. Please give a warm welcome to Professor Mujib Abbasi.
Thank you very much. Assalamu alaikum. Welcome everybody. इस पे ज़्यादा हम बात बाद में करेंगे. Colorectal Disease Patient Welfare Association was brainchild of our Professor Amjad Raj, now Vice Chancellor JSMU. उन्होंने टीम डेवलप की. That idea came around in 2011. उसके बाद हम कंटिन्यूस करते रहे, लेकिन बुरा हो इस कोविड का जिसने थोड़ा सा डिसकंटिन्यू करा दिया. हमने दोबारा शुरू किया है. होपफुली यू विल एंजॉय इट. सबसे बड़ी चीज़, दो चीज़ें आपने करनी है. एक तो दिस इज़, आप अगर समझते हैं कि ये इतना सारा एफर्ट है, वो आप लोगों के लिए है जो नए सर्जन्स आना चाह रहे हैं या जो फैकल्टी, जूनियर फैकल्टी है. यही चीज़ आप अगर बाहर करना चाहेंगे, एक तो वीज़ा नहीं मिलेगा, दूसरा इट कॉस्ट अ लॉट ऑफ मनी, और तीसरी सबसे चीज़ कि देयर इज़ नो लैंग्वेज बैरियर के उर्दू में भी बात कर सकते हैं, सिंधी में भी, पंजाबी में. गोरे के साथ बात करते हैं तो पहले तो उसकी चमड़ी देख के परेशान हो जाते हैं कि अच्छी चमड़ी के साथ कैसे बात करें. दूसरा फिर बहुत सारी चीज़ें आपकी रह जाती हैं. हमारा काम आप लोगों के लिए, ख़ास करके जो ट्रेनिंग सेशन है, आपको टॉप मोस्ट फैकल्टी पाकिस्तान की आपके मेंटर्स हैं यहाँ पर, वो आपको हेल्प करेंगे. दूसरा हमारा काम तीली जलाना है, चाहे उससे आप घर को आग लगा दें या दूसरी कोई मशल रोशन कर लें और उसको आगे बढ़ाते रहें. तो लेट्स होप यू विल एंजॉय इट एंड यू विल बेनिफिट इट फ्रॉम मोर. विल कंटिन्यू बी विद यू ड्यूरिंग दिस 2-day sessions and then in the live surgery. So hope you will take a good message with you and it will be very helpful for your training and understanding the colorectal diseases and its problems. Thank you very much.
Thank you, sir. Now, ladies and gentlemen, please allow me to introduce you to the man of hour, the founding chairman of Colorectal Disease Patient Welfare Association and the chief organizer of COLOCON 2022, Professor Amjad Siraj Memon. He is currently serving as Vice Chancellor at Jeddah Sindh Medical University. He is an eminent general surgeon with special interest in laparoscopic and colorectal surgery. He has played a monumental role in establishing the first, one of its kind, public sector colorectal unit in Pakistan. Please give a huge round of applause for Professor Amjad Siraj Maiman. Sir, if you could please come on stage and honor us with your wise words.
Bismillah ar-Rahman ar-Rahim, and Assalamu alaikum to all of you. It's so nice to see old familiar faces. मैं उस दिन किसी को बता रहा था कि 1981 में मेरा एडमिशन हुआ और 21 में मैंने छोड़ा यहाँ से. छोड़ा अभी तक नहीं है एक्चुअली, मैं अभी भी प्रिंसिपल साहब के अंडर काम करता हूँ. मैं अभी आज इनको कह रहा था कि आई हैव अ लियन, तो अभी 1-1.5 महीने के बाद मेरा रिटायरमेंट आएगा, उस वक्त तक मैं अभी भी आपके छतर छाया में हूँ. लेकिन 40 years I have been associated with this college and hospital. तो बहुत साल पहले जो है वो I got injured and I got a new life really. And that was the time somebody came to me in the ICU where I was lying. And he said कि अल्लाह ने आपको ये ज़िंदगी दी है तो किसी न किसी मकसद के लिए दी होगी. यकीन करें उसकी बात मुझे ऐसी इन डेप्थ लगी थी वो कि उसके बाद मैंने ये जो कोलोरेक्टल बातें तो मैं करते, सब लोग कर रहे थे, अपर जे साजिदा पता नहीं कब से कर रही है, बाद में उसमें बैरियाट्रिक भी ऐड कर दिया, तो इस तरह बाकी सब चीज़ें सब कर रहे थे, लेकिन कोई एज सच वो डिफाइन नहीं था. फिर सईद साहब को ये क्रेडिट जाता है, उन्होंने वो डिवाइस कर दिया कि भाई तुम ये करो, तुम ये करो, तुम ये करो, तुम ये करो. उससे इंप्रूवमेंट आई है, बहुत ज़्यादा इंप्रूवमेंट आई है, जो आपको अभी नहीं नज़र आएगी. जब आप इधर से बाहर निकल के जाएंगे तो आपको बाकियों का हाल आपको पता नहीं है. इस वर्कशॉप की बात करें, इस तरह के वर्कशॉप, अभी मैं डॉक्टर साजिदा से वहाँ बात कर रहा था कि हमने जब वार्ड बनाया था तो उसका एक बजट होता है. उस बजट में मैंने 2 स्कोप मांगे थे. एक स्कोप जो था फॉर पर्पस ऑफ ट्रेनिंग था और एक था जो अभी भी आपके पास इस्तेमाल हो रहा है उधर अंदर थिएटर में, इसलिए कि आप ये रूटीन लैप्रोस्कोपी, कोलिसिस्टेक्टमी, हम सर्विस प्रोवाइडर्स हैं, आपके पास 4 केसेस लैब को लिए करने हैं, आप रेक्टम कब करेंगे? आपके पास टाइम ही नहीं होगा. आपके पास इतने सिफारिशें, इतने प्रेशर आते हैं पित्ते करने के लिए कि, और फिर जूनियर्स को शौक भी होता है कि हम सीखें. रेक्टम में उनको सिर्फ कैमरा पकड़ना पड़ेगा, तो काफ़ी सीनियर रेजिडेंट्स होते हैं जिनको कैमरा पकड़ना भी नहीं आता. और मेरा अपना व्यू ये है, वेरी वेरी स्ट्रांग व्यू, जिसको कैमरा पकड़ना नहीं आता वो कभी भी सर्जन नहीं बनेगा, सवाल ही पैदा नहीं होता. दैट पर्सन विल बिकम अ वेरी ऑर्डिनरी मीडियोकर थर्ड रेट सर्जन. अच्छा सर्जन बनना है तो आपको ज़्यादा से ज़्यादा असिस्ट कराना चाहिए. यहाँ पे एक होती है कि मेरी मूछ बड़ी है कि मैंने आज इतने हर्निया किए, मैंने आज इतने किए, वो किए. नो, एक करो लेकिन अच्छा करो. और ये जो अब आज जो मैंने आपकी क्वालिटी ऑफ जो सिमुलेटर्स देखे हैं, दे आर ब्रिलियंट. एंड ऐसे इतना ब्रिलियंट तो नहीं है, लेकिन एक पुराना अच्छा खासा नया है, वो भी इतना पुराना नहीं है, 7-8 साल पुराना, इतना पुराना नहीं होता है. नए वर्जन्स आ जाते हैं तो इसलिए आप उसको पुराना कह रहे हैं. वो आपके मिनिमल एक्सेस यूनिट आपके थिएटर के अंदर है. आई डोंट नो हाउ मेनी नो अबाउट इट. और 35 लाख रुपए का वो सिमुलेटर था जो मेरे वार्ड में मैंने लिया था, और मैंने उसको सईद साहब को कह के हमने उनको वहाँ इंस्टॉल किया. हमने रोस्टर, जुबैर साहब को हमने इंचार्ज बनाया था कि रोस्टर करो कि रेजिडेंट्स फ्रॉम द 2 यूनिट्स शुड डू. सर को ले आए. I welcome the great man, the great teacher, Mumtaz Mahar sahab. He's been my teacher. I was very fortunate. I was in 3rd year when sir joined here as assistant professor, and फिर जल्दी से भाग गए हमारे पास छोड़ के हमें. अच्छा, so what I was saying was इतने अच्छे, अब मतलब इससे बड़ा क्या आपके पास जाइंट आएगा सर्जरी का जो आपको सिखाने आए, और आप उसके बावजूद अगर आप इंटरेस्ट नहीं लेंगे तो you will not become a good surgeon, I tell you. Practice makes a man perfect. हमारी ज़्यादातर जो सीनियर सर्जन्स हैं उनकी गोट फंसती है इसमें इंटरकॉर्पोरल सूचरिंग में, ज़्यादातर की फंसती है गोट. वो भी कोई इतनी बड़ी चीज़ नहीं. यू जस्ट हैव टू स्टार्ट डूइंग इट. इतने बेहतरीन किस्म के सिमुलेटर आपके, ये बता रही थी वार्ड में भी पड़े हैं 2. आपके वार्ड में है वो, और आप जाके बैठ के वर्कशॉप की आपको जरूरत क्यों पड़ती है? इसलिए यहाँ पे आपको गाइडेंस मिलेगी, आपको अच्छा सही तरीका मिलेगा। आज जब आप एंड ऑफ द डे यहाँ से निकलेंगे तो द टेक होम मैसेज इज इट इज ओके टू लर्न फ्रॉम सीनियर्स। एक सीनियरिटी लेवल आपकी अपनी आ जाएगी, उसके बाद जो है ना आपको अजीब सा लगता है मैं कैसे इससे सीखूंगा, मुझे लोग सोचेंगे इसको आता नहीं है। कोई बात नहीं, वन कीप्स लर्निंग। मैंने रिसेंटली एक टेक्निक मैंने एक गायनोकोलॉजिस्ट को करते देखी OMI हॉस्पिटल में, नीडल पकड़ने की सर। मतलब उसको नीडल को जिस तरह हम पकड़ते हैं यूं बाइट किया और धागे वी स्टार्ट टाइंग द नीडल इज एक्सपोज्ड, शी जस्ट टर्न्स द नीडल इन सच अ वे कि वो जाके अपनी नीडल होल्डर पे जाके खड़ी हो जाती है और वो सवाल ही नहीं आपको इंजर करे। सच अ गुड टेक्निक, तो इट्स ओके टू लर्न, व्हाट्स द प्रॉब्लम। हमने वीडियो भी बना के, आपको पता नहीं ये लोग शेयर करेंगे इस वर्कशॉप में या नहीं, टू क्लोज द पोर्ट साइड हर्निया से बचने के लिए एक सिंपल टेक्निक थी, हमने लगाई, सर्जिनेट पे लगाई हमने। सर्जिनेट वालों ने बहुत अप्रिशिएट की। सिंपल टेक्निक है, किसी से सीखी थी, हमने आगे शायद शेयर कर दी। सो वी आर हेयर टू शेयर आवर एक्सपीरियंसेस। आई एम वेरी ग्रेटफुल टू द सीनियर सर्जन्स हेयर जो इतनी मेहनत करके अपने रेजिडेंट्स और जूनियर सर्जन्स को ट्रेन कर रहे हैं। आई एम वेरी हैप्पी कि एक दिया हमने जलाया था कोलोरेक्टल डिजीज पेशेंट्स वेलफेयर एसोसिएशन, इट हैज प्रोग्रेस, थैंक गॉड कि कोविड से जान छुटी और वापस कोलोकॉन हो रहा है, आज से शुरू हुआ है बेसिकली। एंड आप आगे जाके देखेंगे चीमा साहब और ताज कुरैशी आ रहे हैं ना, सो दे आर ब्रिलियंट सर्जन्स। और सर्जन्स के साथ साथ बड़ी बात जो होती है ना, सर्जन बहुत बड़े बड़े हमने देखे, लेकिन एटीट्यूड जो आ जाता है ना वो मुमताज साहब में नहीं आया, कभी साजिदा में नहीं आया। अगर आप चीमा साहब से मिलेंगे तो आपको नजर आएगा कि ही डजंट हैव एनीथिंग। उसके इतने प्यार से बात करते हैं वो कह रहे थे एक दिन, द बेस्ट लाइन आई थॉट ही सेड वाज, वो कह रहे थे कि यू माइट थिंक दैट आई एम स्लो बट स्लो इज फास्ट। जबरदस्त लाइन है, स्लो अगर आप अच्छा कर रहे हैं बेशक स्लो करें, क्योंकि अगर आप मेसअप करेंगे जल्दी करने में तो उसमें आपको कॉम्प्लिकेशन होगी, उसको सीधा करने में घंटा एक्स्ट्रा लग जाएगा। सो इस वर्कशॉप से मैक्सिमम फायदा उठाएं। आई एम ऑल्सो ग्रेटफुल टू दी मेडिकल सुपरिटेंडेंट जो बेचारी बहुत हमारी हेल्पफुल रहती हैं हमेशा, और आज वादा करके गए, हम वादा लेके इनको छोड़ेंगे कि ये सारे इंस्ट्रूमेंट्स जो हमारे वर्कशॉप में इस्तेमाल होंगे वो ये प्रोवाइड करेंगी इंशाल्लाह। ठीक है ना? थैंक यू वेरी मच।
Thank you, sir. For the formal inauguration of event, I would like to call on stage Professor Dow Medical College, Dr. Sabah Suhail. She is a consultant radiologist and had been working as head of department radiology in civil hospital. Please put your hands together for Professor Dr. Sabah Suhail.
Assalamu alaikum. This is a very proud moment for me to declare this, inaugurate this particular pre-conference workshop. I know that our faculty has been arranging this COLOCON conference for many years till it was interrupted by this coronavirus pandemic. And I'm very glad that our faculty is DMC faculty is very active in arranging this workshop. As we all know, instruments are there, patients are there, teachers are there. What it needs is the will within the juniors to learn. आप लर्न करेंगे। जिस वक्त मैंने यहाँ ट्रेनिंग की थी उस वक्त यहाँ सिर्फ अल्ट्रासाउंड होता था और एक्सरे होता था और फ्लोरोस्कोपी होती थी। When I had passed FCPS तो लोगों को यकीन नहीं आया था कि सिविल हॉस्पिटल से किसी ने FCPS कर लिया। बट आई कंप्लीटली गारंटी यू, मैंने जो कुछ भी सीखा था यहाँ पेशेंट्स से सीखा था। जितने मेरे पास पेशेंट्स आते थे मैं उनकी सारी फाइल्स देखकर और उनकी सारी इन्वेस्टिगेशंस को फॉलो करती थी। दैट मेड मी a fellow from civil hospital, the first fellow in radiology from civil hospital. But I assure you, civil hospital से जो लोग सीख कर जाते हैं, they are so trained and they are so well versed in handling the complications that you people should be considered fortunate to be trained here. आप सब लोगों का बहुत शुक्रिया कि आपने मुझे यहाँ बुलाया. आई होप ये कॉन्फ्रेंस और ये वर्कशॉप अपने ट्रेडिशंस के मुताबिक इंशाल्लाह बहुत फ्रूटफुल और करामत साबित होगी. थैंक यू सो मच. अस्सलाम वालेकुम.
Thank you, ma'am. Now, it will give me great pleasure to invite our esteemed Professor Amjad Siraj Memon to come up on stage and present to Professor Sabah Suhail with the Shield of Honor on this monumental occasion. Now, I would like to call MS Civil Hospital to say a few words with us.
बिस्मिल्लाहिर्रहमानिर्रहीम. अस्सलाम वालेकुम. मेरे मुअज़्ज़ज़ कलीग्स और सीनियर मुमताज़ महर साहब, आप सबका बहुत शुक्रिया कि आप लोगों ने मुझे इस काबिल समझा और मुझे ऑनर दिया कि मैं आज यहाँ आप लोगों के साथ मौजूद हूँ. और मुझे उम्मीद है जिस तरह से प्रोफेसर अमजद सिराज साहब काम कर रहे हैं कोलोरेक्टल के लिए और जो इन्होंने एक काम शुरू किया है और जिससे इतने लोगों को फ़ायदा हुआ है, इंशाल्लाह ताला ये सिलसिला चलता रहेगा. उसमें हमारे तमाम सर्जन्स, हमारे तमाम कलीग्स, हमारे प्रोफेसर साहिदा कुरैशी साहिबा, हमारी प्रिंसिपल साहिबा और तमाम हमारे साथी इसमें हमेशा हमारा साथ देंगे. और जहाँ तक मुमकिन है मेरी पूरी कोशिश होगी कि महदूद बजट के होते हुए जो कुछ मैं कर सकती हूँ और जो कुछ मैं प्रोवाइड कर सकती हूँ इंशाल्लाह करती रहूँगी और आपकी हर तमाम काविशों में मैं आपके साथ हूँ. शुक्रिया.
Thank you, ma'am. We are indebted and delighted that you all have decided to participate in this workshop to acquire skills from the nation's leading expert in the area of laparoscopic surgery. Let us introduce you to the participants for today. This is the era of laparoscopic and robotic surgery. A recent increase in the number of reports, retrospective analysis, randomized trials, and multicentric trials have provided a significant data to support the role of laparoscopy in colorectal surgery. Hence, we are here today to acquire skills in some of the laparoscopic techniques from the leading surgeons in this field. Ladies and gentlemen, please allow me to introduce our chief guest, our master trainer, Professor Mumtaz Mahar. He is among the pioneers of laparoscopic surgery in Pakistan. He specialized in bariatric and metabolic surgery and is currently the president of Pakistan Society for Bariatric and Metabolic Surgery. Throughout his career, he has been involved in training surgeons from across Pakistan in minimally invasive surgery. Please give a warm welcome to Professor Mumtaz Mahar.
Assalamu alaikum. Thank you very much. It's always nice to come back to Civil Hospital Karachi, where I started my surgical career a long, long time ago. It's always nice to come and meet people that I've known over the years. What is heartening is to see that despite the 2 years of loss of time with COVID, we are back into activities. And this is what these institutions are all about, to train people. And what I feel is, if I see some junior come up to a certain level of expertise and something goes wrong, I don't blame him. I feel, itna hi sikhaya, usse zyada nahi sikhaya. And that is happening a lot now, that if the teaching and training suffers, the product we create and send into the market or for the society in general, is that quality is going down. And it is to people like Amjad Siraj and Sajida that they're doing excellent work and people are working under them and learning. And these are opportunities that provide us the experience that they bring into a workshop, into these activities, and especially with the endo trainers available, I can't imagine a surgeon who operates and not able to suture. The same applies to laparoscopic surgery. If you're going to operate, sooner or later you will need, or the occasion will arrive for you to put a stitch in or to tie a knot. And this can be learned on the endo trainer. The endo trainers are available, but something is missing. I don't see youngsters practicing on them. And this is science now. It has been found out that if you spend 20 hours practicing, you actually become very good. And when the time arises, when there's an emergency or a need for do this on a patient, that is not the time to learn. You should have known it earlier. You should know the principle. You should know how to execute a maneuver. And laparoscopy is a little different from open surgery, is that there are rules to go by. Where you place your trocars, what angle do you place your trocars, what distance you place the trocars from the object that you're going to suture on. These are all science and established principles that need to be learned. It can't just happen. Given the wrong set of circumstances, even experts struggle. An expert or a master will be able to execute a maneuver, but find it difficult because the trocar was not placed right or the angle was not right. These are two things that you need to understand. Third thing that you have to have is you have to have the tools to do these things. When I started laparoscopic surgery, when the world started laparoscopic surgery, there was no needle holder and people struggled. And the laparoscopic needle holder was invented quite later, a few years later. And then the science developed. Now the science is there. We have the endo trainers. We have the teachers to train. You just need to go look for the trainers. If you go up to anybody who is a teacher and ask him or her to show you how to do something, I don't think they'll say no. In every operating theater, I see that the juniors are sitting outside where a lot of good work is being carried out on the inside. If you want to become a surgeon, you have to have the drive in you, the passion in you, the motivation in you, because that is where your profession is, that is where you're going to make your livelihood. So instead of saying that you're going to become good surgeons, the fact remains that you have to make a living, you have to earn a living. And what is difficult is, when you become a FCPS, you pass your training period, where are you going to learn? That is the time to learn. And how do you go into the market as a general surgeon, like every other? How do people come to you and submit to your surgery if you don't have the skill set or you don't have developed a name? So this is a time to learn and keep practicing. You're actually competing with your own self. You have to be better than what you were last week or the last month or the last year. And that only comes through practice. Over here I see there's a good faculty that they have gathered. They're experienced, they can teach you. I wonder, when I'm called to come here, I wonder, what is my need to be here? What can I offer? These people are just as good as I am. Whenever something is happening and there's a new learning period, at the time of learning, a junior and senior both stay students. They learn together. So do not be shy of learning from anybody, wherever the learning comes from. Do not be shy. Learn it and show respect and gratitude for the person who has taught you or who has arranged all this. Amjad has done a good job, and I'm sure if there's anything I can contribute to being here, I'd be willing to do it. But the faculty is very good. They're good teachers. They're experienced. They've learned it all. Practice, and then once this is over, go to your house, to your home, to the ward, and use the endo trainer and time yourself, clock yourself, learn the maneuvers that need to be learned. And I'm sure when the time arises and you need to suture, you will be available to do it. You'll be readily doing it, and there'll be a sense of accomplishment that you've done something. I wish you all well. Thank you.
Thank you, sir. Now, it will give me great pleasure to call Professor Amjad Siraj Memon to come up on stage and present to Professor Mumtaz Mahar with the Shield of Honor. Shield भी देंगे सर. Without any further ado, let's start with our first session on hands-on workshop. This session entails laparoscopic ergonomics and needle handling. This session will be conducted by Professor Sajida Qureshi. She is a distinguished general surgeon specialized in upper GI bariatric, laparoscopic and robotic surgery. Her advanced laparoscopic workshops are famous, and today we have the privilege to have her as the chief facilitator. Let's welcome her with a big round of applause, Professor Sajida Qureshi.
Assalamu alaikum and good morning, everyone. Thank you very much for your kind words. It's an honor to be here in company of my two great teachers sitting here, Professor Mumtaz Mahar and Professor Siraj Memon. So without much delay, I think we'll start with our workshop for today. So before we start, so what I would like to do is, you know who I am, and I'm here to try to, help you go through a few things that you find difficulty in whenever we are talking about laparoscopic surgery. But before that, I would like you people to introduce yourselves, and we would like to know what are your expectations from this workshop, and what is your experience, what have you been doing so far. So if we can have the mic to the first candidate. Who are the candidates? Can you please raise your hands? Okay, good. So we have got quite a few. So we'll start with you, Dr. Saab, here. So please introduce yourself, where you're working, and what is your experience of laparoscopy, and what are your expectations from this workshop today?
बिस्मिल्लाहिर्रहमानिर्रहीम। मेरा नाम डॉक्टर मोहम्मद यासीन है। मैं जनरल सर्जन हूँ और मैं पाकिस्तान पेट्रोलियम लिमिटेड का हॉस्पिटल है सुई में, सुई फील्ड हॉस्पिटल, उसमें काम कर रहा हूँ। और 2015 से मैं लेप्रोस्कोपी कर रहा हूँ। मैंने वहाँ शुरू भी की थी और प्रोसीजर्स जितने भी हैं मैंने यहाँ JPMC में और मुमताज़ साहब से भी काफ़ी मैंने लर्निंग की। मैं अभी वहाँ पर लैप कोली, लैप अपेंडिसेक्टोमी, हर्निया में TAP और TEP दोनों, और लेप्रोस्कोपिक टोटल हिस्टेक्टोमी, ये तमाम चीज़ें वहाँ कर रहा हूँ रेगुलर बेसिस पर, और अल्हम्दुलिल्लाह रिजल्ट्स बहुत बेहतर हैं। और यहाँ मैं कराची में जो भी कहीं लेप्रोस्कोपी की वो कॉन्फ्रेंस या कोई इस तरह की ट्रेनिंग होती है तो मैं कोशिश करता हूँ अटेंड करने की। आल्दो मेरी थोड़ी सी एडमिनिस्ट्रेटिव असाइनमेंट्स अब कंपनी में काफ़ी बढ़ गई हैं, लेकिन ये आपकी जो ट्रेनिंग है इसको जब देखा मैंने तो मुझे बहुत इंटरेस्ट डेवलप हुई, क्योंकि स्पेशली इंट्रा कॉर्पोरियल सूचरिंग में जो है वो मैं शायद उस तरह उतना वेल वर्स अभी तक नहीं हूँ। हालांकि मैं प्रैक्टिस घर में भी करता रहता हूँ, तो मेरी एक्सपेक्टेशन ये है कि इंशाल्लाह मैं जिस तरह से इतने सीनियर टीचर्स अल्हम्दुलिल्लाह इस वर्कशॉप में मौजूद हैं तो यकीनन बहुत ज़्यादा इंशाल्लाह लर्निंग होगी।
So you're mainly interested in suturing, learning. Otherwise, you are well acquainted with the equipment and how to. Okay, fine. Dr. Kanaya.
I am Dr. Kanaya Lal. I am working as a general surgeon in Sindh government in district Ghodki for last 18 years, and I have started laparoscopy in 2014, and I came here in OT complex in 2014 under supervision of Professor Said Qureshi to refresh me, because for a long time I couldn't use laparoscopy instruments. Now I am doing laparoscopic cholecystectomy, appendicectomy, diagnostic laparoscopy, and simple procedures like liver abscess, drainage, and lymph node biopsy. But I use extracorporeal knots, but intracorporeal suturing I am deficient in this procedure. So my expectation is to learn mainly intracorporeal suturing.
So not tying and suturing,
Yeah,
right?
yeah.
Okay.
Assalamu alaikum. My name is Dr. Farhan Ali, currently working as Senior Registrar General Surgery, Gumbert Institute of Medical Sciences, Gumbert. I postgraduated from Mayo Hospital, Lahore. I did couple of workshops on basic surgical skills, laparoscopic surgical skills from different workshops. Here I want to do the advanced laparoscopic surgical skills so that I can implement at my center and do further in this field.
So have you ever tried knotting and suturing intracorporeal?
Yes, ma'am. In couple of workshops I did,
Okay.
but later on I forgot because I wasn't.
All right,
practiced
okay,
that.
fine.
मैडम मेरा नाम डॉक्टर गुलनसीब खान है। मैं बडग्राम हज़ारा डिवीज़न से आया हूँ केपी से, और कोई बिगिनर हूँ मैं लेप्रोस्कोपिक सर्जरी में। मैंने कोई 7-8 इंडिपेंडेंट कोलिसिस्टिक लैब कोलीज की हैं, लेकिन इंट्रा कार्पोरियल और एक्स्ट्रा कार्पोरियल सूचिंग बिल्कुल इससे पहले एक वर्कशॉप अटेंड की थी, लेकिन वो उसमें मुझे हार्डली 5 या 10 मिनट्स मिले थे सूचरिंग के। तो इससे लर्न करना चाह रहा हूँ इंट्रा कार्पोरियल एक्स्ट्रा कार्पोरियल दोनों सूचरिंग। और लेप अपेंडिसेक्टोमी अभी तक मैंने नहीं की, सिर्फ कोलिसिस्टेक्टोमी, वो भी 7-8।
Okay.
Assalamu alaikum everyone. I'm Dr. Tayyib Siddiqui, currently working in Patel Hospital as junior faculty. I'm sorry for the voice. I have attended the similar workshop previously, and it really helped me in giving me confidence that I can do it on the patient. So just want to have more confidence after the end of the day.
So when did you last attend this workshop there?
Few months back that we had this
Okay, all right. So you thought that you had learned something from that workshop, or you did not? That is the reason you are back. You want to have more confidence. Okay, fine.
Assalamu alaikum. My name is Dr. Fatma Yusuf. I am a resident at Surgical Unit 2 Civil Hospital, Karachi, and I want to learn the basic principles, basic instrument handling, and also added advantage would be to learn intracorporeal and extracorporeal knotting.
Which year are you in?
R4.
R4, okay.
Assalamu alaikum. My name is Dr. Hafiza Bushra. I'm general surgery resident in Surgical Unit 2 Civil Hospital, Karachi, and I want to learn basic principles and instrument handling in laparoscopic surgery.
So have you done any lab colis prior?
Ma'am, almost 3 to 4.
3 to
Not more
4,
than
okay,
that.
fine.
I'm Dr. Kamal Sikandar, general surgery resident in Civil Hospital, Karachi. Since I'm under my training, so I am expecting to have a good experience over here. I just want to improve my basic skills, and I have done 2 to 3 lab colis recently, so I am expecting that I'm having a really good experience since we are having a lot of mentors here. So
okay.
Assalamu alaikum. My name is Dr. Kamal Nissa. I'm a general surgery resident starting my year 4 of residency in Patel Hospital. Since I'm a trainee surgeon, so I'm interested in the entire outline and want to improve my basic skills for the laparoscopic surgery. So interested in all the principles and suturing as well.
All right, okay.
Assalamu alaikum. I am Dr. Alim, currently working as general surgeon in Walika Hospital, and I want to enhance my laparoscopic skills regarding suturing and knotting. And currently I am doing lab appendicectomies and lap colis.
Okay.
Assalamu alaikum. My name is Dr. Harim Fatma Hussain. I'm currently working at Hashmani's hospital. I came to a similar workshop that was held by you last year, and it gave me enough confidence to be able to perform laparoscopic cholecystectomies. So I'm here for a refresher course and also to add to that repertoire.
Yeah.
Assalamu alaikum. I'm Dr. Zakia Madat Ali, surgical resident at 3 at Surgical Unit 2. I'm here to have a better understanding of basic principles of laparoscopic surgery and knotting suturing.
Okay.
Assalamu alaikum. My name is Dr. Marine Ansari, and I'm a third-year resident at Surgical Unit 1 Civil Hospital, Karachi. I feel these workshops are a great place for us to get oriented and utilize the simulators for practicing our advanced laparoscopic skills and get a basic idea. So hence I'm here. Thank you.
All right. Who's left? Anyone left? Can we have the mic on that side, please?
Assalamu alaikum. I am Dr. Jahara Hassan, working as a consultant general surgeon at District Ghodki. I am doing laparoscopic cholecystectomy, and here I am here to learn intracorporeal and extracorporeal knotting and suture.
Assalamu alaikum. I am Dr. Sabha Nazir, working as a resident general surgery in Surgical Unit 5. I'm here to learn basics of laparoscopic surgery, basic economics, with an added exposure to intracorporeal suturing.
Assalamu alaikum. My name is Dr. Sumla Salman and I am a resident in Surgical Unit 6. I've had some exposure in laparoscopic cholecystectomies. I am here to fulfill my deficiencies, whatever there are in basic principles, and move on to some advanced skills.
Assalamu alaikum. My name is Dr. Hassan Shahab, resident Surgical Unit 6, Year 4. Just attending my first laparoscopic workshop and excited to learn new things from it.
Assalamu alaikum. My name is Dr. Komal. I am resident Surgical Unit 5, Civil Hospital, Karachi. I want to learn the basic principles of the laparoscopic surgeries.
So have you done laparoscopy before?
Yes.
Assisted? Okay.
Laparoscopic cholecystectomies 4 to 5 and
Okay, good.
laparoscopic
Good, fine.
appendectomy.
Next.
Assalamu alaikum. I'm Dr. Bushra Javed, Air Force resident in Surgical Unit 5, Civil Hospital, Karachi. I want to learn the basic laparoscopic skills and move. I have done laparoscopic cholecystectomies 3 to 4 and just hone on my skills more and move forward.
Next, please.
Assalamu alaikum. My name is Dr. Sobia Rafi. I'm working as a consultant general surgeon in a couple of private hospitals in Karachi. I've been doing regularly laparoscopic cholecystectomy, appendectomies, and ovarian cystectomies, and doing intercorporeal knotting as well. But I want to get more exposure in intercorporeal suturing. So my I will be focusing on that. Thank you.
I'm Dr. Rajpat, Year 4 resident at Surgical Unit 4, Civil Hospital, Karachi. I am doing laparoscopic procedures like cholecystectomy, appendectomy, and few more. But I have assisted a lot of procedures. My main learning purpose in this whole workshop, including basics and further intercorporeal knotting.
Assalamu alaikum. I am Dr. Yusra, working as a resident Year 3 in Surgical Unit 4, Civil Hospital, Karachi. And talking about this workshop, I am keen to learn the basics of laparoscopic surgery, from instrument handling to different types of suturing.
Assalamu alaikum. My name is Dr. Aneza. I'm a 4th year resident in Surgical Unit 6, Civil Hospital, Karachi. I attended your workshop last year as well. That gave me a lot of insight into the basic principles. Today, my keen interest is learning intracorporeal knotting.
Okay. So that's it? Okay, so we have a mix of candidates here. There are people who have been doing quite advanced procedures, and there are beginners as well. So please, let's make it a very interactive sort of a workshop. It's not going to be a lecture. So what we would need is input from you. If you people do not understand anything, please feel free to stop us there and then, and we can discuss, we can demonstrate. So it's going to be pretty informal. All right. So since majority of you know what laparoscopy is, and the best way, because it's the way forward. Nowadays, you cannot go into your practical life without learning minimally invasive skills. And these minimally invasive skills include both your laparoscopic as well as the robotic surgery. And the best way to learn and the safe way to learn is to learn on simulators. And these sort of workshops, they give you an opportunity to avail this opportunity that you have been given to learn in front of your mentors under supervision, because supervision is a must. All right. So I'm sure all of you must know what laparoscopy is, why is it done, when it is done. So if somebody asks you what are the indications for doing laparoscopic surgery, what would be your answer? Or rather, if I ask you, since all of you have been doing laparoscopy, what are the prerequisites for starting laparoscopic surgery? Can I just stand up today and say, oh, I'm going to do laparoscopic surgery because it's a very new in thing nowadays to do? So, anyone? What are the prerequisites? This, I think, each one of us should know. Come on, anyone? Sorry?
Proper training of laparoscopic.
Excellent. So I think that what is most important in this technique is you should be trained to do laparoscopic surgery. Okay, should not be that thing that you have seen one, assisted one, and you start doing the procedure. Remember, laparoscopic surgery is very complex surgery. It has a very steep learning curve. And each of the surgery, each of the different procedure has got a different learning curve. And you have to achieve that curve before you go on and start doing laparoscopic surgery. So if I'm very good at doing laparoscopic cholecystectomy, that does not mean that I would tomorrow stand up and start doing laparoscopic colectomy or gastrectomy for that matter. All right? So what is most important is to achieve your learning curve, and for that you need experience, you need learning, you need teaching for it. All right? What is the second thing that you need for doing laparoscopic surgery?
Training of the whole team, the other staff members.
So you need to have a trained team. Can we give chance to others to speak as well? There should not be one person. I told you this has to be interactive. We'll not go far if you people just sit quietly, okay? So yes, you should have proper equipment, you should have a proper theater layout, and you should have a trained team. Like Dr. Amjad said at the beginning, you should know how to hold the camera. If your camera person is not trained, your skill as a good laparoscopic surgeon would not do much good to you, actually. Because if the camera person is not showing you where you want to see on time, that's going to make the process tedious and not very efficient. Okay, so what are the contraindications? When would you not do laparoscopic surgery? Nowadays, laparoscopic surgery can be utilized for any surgery that you are trained for. You have proper equipment, you have proper theater accessories and equipment with you. Okay, so what are the contraindications? When would you not do laparoscopic surgery? These are all the things that I usually teach when I'm doing a basic laparoscopic workshop, and I expect all of you to know that. What are the contraindications for doing laparoscopic surgery? When would you not do it? No, that's not a contraindication. Nowadays, majority of the emergency surgeries are taken up laparoscopically as well. What is the contraindication?
Cardiopulmonary.
Okay, so first of all is training. Okay, we have sorry? Yeah, that's what we have emphasized. The training is must. Apart from that, clotting disorders, these are all relative contraindications for open as well as laparoscopic surgery. We're talking specifically about laparoscopic surgery here. What would be, which would be those situations where the patient will not be tolerating pneumoperitoneum? So people who are severe cardiopulmonary compromise, then it depends on what the status is and how does your anesthesiologist feel about it. If you want to do a small diagnostic procedure and your anesthesiologist is happy to give anesthesia for a shorter duration, you can perform that procedure. Okay, so how do you learn? Laparoscopic surgery, we have all established, it has got a steep learning curve. Why do I say it's got a steep learning curve? Huh? Anyone? How is it different from open surgery? Why do you think it takes a longer time for you to learn laparoscopic surgery as compared to open surgery? Hand-eye coordination. So you're looking at the monitor, you're operating at a site which is distant from where you want to operate. Your target organ is far away. So you're operating from the abdominal wall or the skin, and your target organ is far away. You're looking at the monitor, you're not directly looking at the site where you're operating. So you have to have. So the best way we have established is to work in a safe simulated environment like what has been provided for you today. So what problems do you have when you're doing laparoscopic surgery? Why do you think it's difficult? Apart from this hand-eye coordination, anything else that would make it a more challenging procedure? Very good. So what do you understand by depth perception? That you cannot perceive the depth adequately when you're doing laparoscopic surgery? Yes? Why do you think it's so? And how can you overcome it?
Because it usually provides two divisions.
Okay, so one is that when you're doing open surgery, you have got 3D vision. When you're doing laparoscopic surgery, you just have two-dimensional vision, okay? So one is that, one is the hand-eye coordination. Third is inability to perceive the depth. What else? Loss of tactile feedback. What do you understand by this term? What is tactile feedback?
We cannot touch the tissue by our hand.
So how does it help? I understand that tactile feedback is when you touch, it's soft, it's firm, it's hard. How does it implicate you're doing the surgery?
Laparoscopically, maybe we can injure some organ
because you do not know how much traction, how much force you have to apply for that, but how firmly you have to hold, how softly you have to hold. So all this makes it a procedure that would need lot of experience and lot of a steep learning curve. So these are all the challenges that you face in laparoscopy. You have got two-dimensional vision, you have got lack of tactile sensation, lack of depth perception. You have to be bidextrous. In open surgery, you can get away working with your right hand only if you're a right-handed person. But in laparoscopy, remember, you have to be bidextrous. Otherwise, you're not going to be a good laparoscopic surgeon. You should know how to hold the instrument, how to hold the needle with both the hands. Sometimes you have to go and apply a stitch from your left hand. You cannot, if you're holding a critical tissue in your right hand, naturally you're not going to leave that and then grasp it with your left hand and then use your right hand to take a knot or suture through it. So you should be bidextrous. Okay, so hand-eye coordination. And the other important thing that makes it more challenging is fixed range of movement. See, your human wrist has got a 360-degree movement. I can move my wrist all around. Whenever we're doing laparoscopy, you're working with stiff, long instruments. And how much degree of freedom do they allow you? Only 4. What are the movements that these laparoscopic instruments allow you? Up, down, in, out, right, left, clockwise, anti-clockwise talk, isn't it? So you have to overcome this, and how do you overcome this? Is by experience. Keep on training, keep on training, keep on practicing. Okay, so laparoscopic geometric principles. So the 3 main obstacles that affect your initial learning curve is your visualization, okay, lack of depth perception, and fixed range of laparoscopic ports. Okay, so how do you overcome each one of those? What do you mean by visualization? I thought in laparoscopy you get a magnified view, isn't it? So why is visualization a problem in laparoscopy? Anyone? Think about it, because you people have been doing it, and this you all agreed was something which was quite challenging in laparoscopic surgery.
If camera skills are not appropriate, then we cannot visualize the things properly. And if pneumoperitoneum is not appropriate, then
We're just talking about, let's limit ourselves to the visualization thing. So it's good, isn't it? If you see a magnified view, that's good. So why is visualization a problem? So there's loss of peripheral vision. So there's a panoramic view and there's a magnified view. So how does it help? So since you have a 2D vision, there's lack of depth perception, so you would not be able to know how much far it is. So what is it affected by visualization? Visual distance and visual angle. What do you exactly mean by that? When I'm saying this might seem quite difficult for you to understand, but what is visual distance? If I bring in my camera, how far is this camera from my target organ? This is your visual distance, right? And what is the visual angle? The angle that your camera is making with your target anatomy, that's your visual angle. How does it affect the surgery? Does it affect the surgery? Why? Because if the target organ is at an angle, it's up, it's down, it's in a crevice, in a cavity, naturally if you go closer, then it's going to make it more easier for you to appreciate it. Yes? So what is visualization? 2 main factors affect visualization, your visual angle and visual distance. So remember, these are inversely proportional to one another. So as the visual distance decreases, it increases your visual depth, and it gives you a good depth perception. This is commonly known when you're doing surgery or when you're assisting a surgeon. You would hear him tell you time and again, come closer, come closer, come closer, bring the camera closer, right? So this is what it achieves. So if your camera is quite far from your target organ, you'll not be able to perceive the depth adequately. For you to perceive the depth adequately, you'd need to bring the camera closer to the target organ, okay? And visual distance, as it increases, it decreases the visual angle, but gives a good panoramic view, but depth perception is lost. Sometimes if you need a panoramic view, you're going to bring the camera back. And when you are bringing the camera back, as the distance increases, your visual angle is inversely affected, and it would give you a panoramic view. Got it? Samajh mein aa gaya sabko? So the two things that can affect or improve your visualization is by manipulating the visual distance and visual angle. Okay? So this is the panoramic view. So what do you mean by panoramic view? What is the visual distance here? Far. And visual angle? No, visual angle is more, or is it less? It's less? It's more. And what is that view? Magnifying view. So 45 degrees visual angle is optimal. So now they have done several studies, and they found that if your visual angle is 45, that gives you optimal depth perception in 2 or more direction between 2 or more structures. Got it? So the other principle that would help you is the triangulation. Okay? So what do you mean by triangulation is? What is triangulation? Okay, so triangulation is the relationship between your instruments, your right hand, left hand, between the assistant instrument and the camera as well. So remember, for you to do an efficient laparoscopic surgery, you need to follow this principle of triangulation. So these instruments at all the time should form apex of the triangle at the target anatomy where you're operating. Okay? And the other thing is that it has got, triangulation has got 3 components, okay? So one is the angle between the instruments. So that's the angle between the instrument and the plane between the instruments and the visual angle, okay? So what are the ideal angles? So you must have, in your exam as well, there's commonly on the OSCE station, they ask you about the azimuth angle and the manipulation angle and the, so this has come, these numbers have come after a lot of research and after a lot of feedback from different surgeons who have been doing laparoscopic surgery. So they have found that the ideal angles for you to do a very efficient laparoscopic procedure is that this manipulation angle and the elevation angle should be 60 degrees. It can be any range from 45 to 75, but the best optimal is 60 degrees. But that doesn't mean that you cannot work at 70 degree. That also helps, depends on the situations. So what is the manipulation angle? It is the angle between your right hand and your left hand instruments, okay? And what is the azimuth angle? Is the angle between your ports, your right hand or left hand instrument and the camera, okay? So that's for optimal, it should be 30 degree. Elevation angle, what is elevation angle, guys? Yes, excellent. So it's the angle between the abdominal wall and your instrument. So this has to be kept minimal 60 degrees. Otherwise, if it's less than that, you'll not be able to efficiently utilize that particular instrument in that particular port position. Because if this angle is less, naturally, if you want to lift something up, so you'll not have enough space for your instrument to go up because it's going to hit against the abdominal wall, right? So whenever you are planning your surgery, you have to plan your ports. This is very important. Laparoscopy does not mean just go and just start doing the procedure. You have to plan for each, especially for the advanced surgeries, you have to plan your ports. Sometimes if you are in an awkward position, you need an extra port to be placed. Naturally, all these principles would help you in deciding where you're going to place your ports. So at all times, keep all these principles in your mind. So what do you understand by this baseball diamond concept and triangulation? People who have attended this workshop previously, I'm sure, would be able to give a feedback on it. What do you mean by that? Nobody knows. Oh, I'm disappointed.
By this, actually, baseball diamond concept meaning is a surgeon and the camera port and the target organ. They should be in the same line.
Okay, all right. So is it something? So let me simplify it for you. What do you mean by triangulation? Each of the instrument that is going in should form a triangle with the camera, with the other instruments, with no matter how many ports you have put in, all the instruments should form a triangle with one another, and the apex of that triangle should be at the target anatomy where you're operating. Okay? So if you do that and then you draw the line, what is this? This is diamond shaped? So this is the concept. So just to simplify it, just remember each one of the instruments should form a triangle and the apex of the triangle should be at the site where you're operating. Okay? So what are ergonomics? So this talk of mine was supposed to be on ergonomics. What do you understand by the term ergonomics? All of you have been doing laparoscopy. There are lots of people sitting here who are consultants, who are faculty, who are doing quite complex procedures as well. What do you understand by the term ergonomic? Interaction between man and machine. Okay. Port placement. Okay, so there's one answer, port placement. So what do you exactly mean by interaction between man and machine?
The operating table should be at a particular height. The instrument should be comfortable at the arm's length, and angulation should not be.
Okay, so all the things related to the laparoscopy would constitute. What does the word ergonomic exactly mean? Work environment. Ergos means work and nomos means the organization. So the science of studying any work, how is it being done? So it would involve anatomy, physiology, psychology, and engineering, like you said, interaction between man and machine. So that is very correct. So ergonomics do not just mean the port positioning. It means your theater layout. It means where your monitor is. It means where you are standing as a surgeon. It means where you have placed your ports. How far are the ports from the target anatomy? What are the instruments that you are using? What is your position in relation to the patient's position or the table's position? So all these things constitute your ergonomics. And without you understanding the ergonomics, you cannot do the procedure efficiently. All right? So what should be the theater layout for doing laparoscopic surgery? What is the ideal theater layout for doing laparoscopic surgery? Anyone? Come on. मैं final year की workshop कराती हूँ, they come up with the answers like this, believe me. What is the ideal theater layout for doing laparoscopic surgery? You're all laparoscopic surgeons sitting here. You just told me somebody has done, I think, even quite advanced procedures as well. Come on. Ceiling mounted tower. What should be the theater layout? What is the correct answer, guys? It depends on what surgery you are doing, isn't it? Right or wrong? So where should the monitor be? Where should I be standing as a surgeon?
Coaxial alignment. There should be coaxial alignment. The monitor should be in front of the target organ. Surgeon and the target and the monitor should be in the same line.
Very good. So remember, the easiest answer is which surgery you are doing. Where is your target organ? The monitor is always placed on the side where you are operating. Surgeon almost always stands opposite to the side where you are operating. Okay? Camera person has always to be on side of patient because he can, of the surgeon, not in front of the surgeon because then the view would be clashing. Okay? What should be the patient's position? It depends on, again, the type of surgery that you're doing or the side you're operating. That side should go up because you want rest of the viscerals to fall away. So theater layout is absolutely must for you to know before you plan the laparoscopic surgery. Okay, so whenever you have a surgery on the list, you tell your resident, this is the theater layout that I want. You do not want the camera, the monitor to be on the same side where you would be standing when you're going in for the laparoscopic surgery, okay? So now coming on to the port placement, very important. If your ports are not properly planned and placed, you'll struggle throughout your surgery, okay? So there are different methods to place the ports. So one is the contralateral port placement. What does that mean? That means you have ports on both the sides. That means right and left side, okay? So what are the advantages? So it provides ideal triangulation and visualization for knot tying, okay? But it has got poor ergonomics. Why has it got poor ergonomics? Because if I have ports on both the sides, I'm going to work like this. So how do I improve the ergonomics? I would improve the ergonomics by just tilting the table towards my side where I'm standing. That's going to improve the ergonomics. All right? So it is going to provide you good triangulation. And it has poor ergonomics, but if you tilt the table towards your side, then that's going to improve your whole procedure. Okay, so ipsilateral port placement. So that means your ports are placed on one side. It can be your right side, left side, depending upon what you are going to do. All right, so good ergonomics, but you do not get good triangulation. But sometimes you need to do that because when you're doing, for example, abdominal wall hernias or something like that, so you need your ports on the same side, or you're mobilizing the colon, you need to stand on one side and do it. So there are different methods to do it, but you should learn the port placement and don't forget the basic principles of triangulation. So if there's a midline structure, then this is how you're going to place your ports. Theater layout we have already talked about. Monitor on the same side where you're operating, surgeon on the opposite, camera person next to the surgeon. Assistant can again be on the side depending upon what you want your assistant to do. All right. So this is how it should be. So do you think this is an ideal theater layout? Why? What's not correct here? Apart from the quality of the picture. What else? What is wrong with the monitors? I cannot make out. So he has got a monitor there. He can always just, look here. Okay, so see, this person would be able to do the surgery. But I think that would be his last surgery that he would do as a surgeon because he's going to have multiple problems at the end of the surgery. And the same would apply to this person here, right? So ergonomics would involve all the time, all these things. So straight line principle, triangulation, manipulation, elevation, low lying table, gaze down view. So what is the ideal position for you to do laparoscopy? Because you see, efficiency of surgery, it's good. Means you have done a good surgery, that's good. But you have to think about yourself at the end of the day as well, because that's not just going to be a single surgery for you. If you're looking at to make it a career for you, you have to look after your own health as well. So why is robotics nowadays so popular is because of this aspect mainly. Because they found that the surgeon-related injuries or hazards are less with robotics as compared to the laparoscopic surgery. So ideal position, remember visual angle to the monitor, 15 to 40 degrees below the line. We usually keep our monitors here. That is the reason we develop what? Surgeon's neck. osteophytes in your cervical vertebra. And remember, your arms should be anywhere between 70 to 120. Ideal would be this, okay? And instruments should be like that. You should be standing straight. And your foot pedal should be at the same level near your foot so you're not struggling. So this was about ergonomics. Let's now come on to the first thing. So this would not take much time. So needles. So most of you said that you were interested in learning intracorporeal suturing and knotting. Before that, I think you need to familiarize yourself with the needle. Okay, so and the different parts of the needle. So this is your needle. Okay, this I'm sure you all know. This is the tip, this is the body. This is the radius of the needle. This is swatch, cord length you need to know, and needle diameter. So for the purpose of this workshop, we're going to divide this needle into 3 parts, okay? There's a proximal 1/3, half, and the distal 1/3, okay? So PX would be the point between the middle third and last 1/3 of the needle. PX. PM is going to be the middle, right? And PB, first third and middle third of this is your PB. All right? PB, PM, PX. Got it? So this is the swatch. So how do you introduce the needle inside? So there are different methods to do it. So there's a direct trocar entry. So if you're using a 5 millimeter port, your straight needle is going to go in directly, okay? For 26 to 36 mm needle, which is the usual size of needle that you would use when you're doing suturing, you would require a 10 millimeter or 12 millimeter port for direct entry, right? So there's another method, backloading. So what do? Grasp the suture 2 to 3 inches from the swatch of the needle. And can we play this, please? No, back, please. Yes. So this is the backloading. Hold it from point A, which is 2 to 3 inches from the swatch. Go in. And that's how your needle is going to go in. Got it? So this is a 5 millimeter. That was a 10 millimeter port, so it went in easily. With this, it's not going because of the size discrepancy. Another method to do it. Take your port out, go in. There you go. All right? So if you have a straight needle, you can directly pass it through the abdominal wall as well. So now needle handling. How do you handle the needle? So there are different methods to tackle that, okay? So once your needle has gone in, you have to utilize some maneuver to hold the needle. So there are different methods to do it. So it's good for you to learn each method, but at the end you can decide whatever works for you. Sometimes 2 or 3 different methods would help you, and sometimes you can just stick on to one method. So there is a method which is known as wake up the needle method or hair pulling maneuver. So what do you do in that? You use point of PX to perform these 2 maneuvers. What was PX, guys? 1/3. This is your PX. PM, middle, you can use it for coffee grinding maneuver. So I'll tell you what these are. These are just fancy names, but the technique, when I'm going to show you videos, you'll be you can familiarize yourself with it, and you would know that yes, this is something that you have seen being done by surgeons. Then there's a flag maneuver, and then you can go for the fine adjustment of the needle. So how do you wake up the needle or hair pulling maneuver? So you use your needle holder to hold the needle from P, what was that? PX, okay? So how do you do hair pulling maneuver? Is that the thread with your left hand is pulled tight with the assistant forceps, exerting traction in a vertical direction towards the abdominal wall, okay? So you grasp it, this needle tip might be pointing anywhere. In order for it to point in the right direction, what you need to do is just pull on this thread don't hold this too firmly, otherwise whatever maneuver you're doing with your left hand would not be transmitted to your right hand. All right? So once you have done that, the needle is in an awake state. What do you mean by the awake state is that the proximal end is angled at 110 degrees with respect to the needle holder p-axis. What do you mean? Look at this. This is the p-axis of your needle holder. This is your needle, and the angle between the two is 110. So that means it's not at the 90 degrees. It's not facing at exactly on the left side, but it's slightly at an angle. Can we play this, please? Excuse me. Hello, play this. So this is coffee grinding. For coffee grinding, this is what? What are they doing? Yes. So all these maneuvers, you'll be now, after this small talk, you'll be required to do it on the simulators. So this is coffee grinding. Hold it from the middle, hold the thread, and try to rotate the needle in your instrument all the way around, okay? And you have to do it with your right hand and left hand. Remember, you have to be bidextrous. Flag maneuver is very easy. For flag maneuver, you have to hold the needle at PB, okay? So, or make it simple, from the proximal end, proximal 1/3, and then you pull the thread up towards the abdominal wall. So that's your flag maneuver. Can we play the video, please? So there are different methods to do it. Now you'll see combination of all the methods here. So what is this? So coffee grind is also known as the dancing needle, so that the thing is the same, okay? Which maneuver are they going to do now? Yes, that was hair pulling, very good. So now with the right hand? Yeah. So this you have to do on your simulators and show it to us, okay? So the idea is you should know how to get the needle in an optimal position to pass it through the tissue. Sometimes it is straight, sometimes when you are suturing, you have to get it angulated. So that is the reason you should know how to, next please, how to fine tune your needle within the needle holder. See, so it's combination of all the methods. So whatever works for you. Initially, you stick on to the one standard technique, and then you can always fine tune it according to what works best for you. See, this is what? Hair pull. So how would you know that the needle is now in an optimal position for you to take the stitch? Anyone? Come on. This was supposed to be answered. How would you know that? Okay, sometimes you want to take a back suture. So what would you do? You would do a coffee grind or a dancing needle and get the needle in an opposite direction to take a backhand stroke, right? Okay. So that's it. So this is a very interesting one, most important one. Keep on practicing. Even if you have to eat with your laparoscopic instruments, do that. That's going to make you a very good laparoscopic surgeon, okay? So now you know, I think they have names put on each one of those stations for you to go and work. You'll be given 15 minutes, if I'm right, yes? 15? Yeah, on each, okay, so 30 minutes for this exercise, come on.
All our participants are enjoying and learning a great deal here. Next session involves laparoscopic intercorporeal knotting. This session will be conducted by Dr. Saeed Ahmed. He is a renowned general surgeon with special interest in laparoscopic bariatric surgery. Currently, he is working as Associate Professor of Surgery in Bariatric Surgery Unit. Please give a warm welcome to Dr. Saeed Ahmed.
Assalamu alaikum, and I welcome all of you. As we have done the first session, which was needle maneuvering, and that was the base of the suturing. If you cannot maneuver the needle and you cannot hold at the proper position, then you cannot move towards the suturing. So it's the basic pillar. And I used to say the needle maneuvering is like needle is like jinn, जिसको जिन बोलते हैं ना. If you have यानी आप इस जिन को अगर काबू कर लेते हैं, then you can move easily, like you can do suturing very easily. So try to practice more and more to hold the needle at proper position. And what is the proper position? It's PX, and the angle should be 110. All the maneuvers which were told you, the basic objective of that was you have to hold the needle at PX, that is towards the swatch, 1/3 swatch towards swatch, and the angle should be 110. If you can hold the needle at this position, then you can do suturing very easily. So try to practice more and more to hold the needle in that position, right? And I would like to deal with, to discuss the next segment, that is knot tying. So basically the suturing has got three parts. One is the needle handling or needle maneuvering at the proper position, then passing the needle through the tissue, and the third segment is knot tying. So I will tell you, I'll discuss with you knot tying, and in the next segment we'll move towards the middle segment, that is how to pass the needle through the tissues. So I will cover the third segment, that is knot tying, and we have done the first, and then in the next session we'll complete, right? We'll do the maneuvering, needle holding, then passing the needle through the tissues, and then third, knot tying. All three things we'll do in the next segment. So in this segment we'll only do knot tying, right? So knot tying is basically, it's extracorporeal and intracorporeal. I will not tell you about the extracorporeal. My topic is intracorporeal, inside the abdomen, right? So it has got three parts. Intracorporeal knotting has got three parts. One is the how to prepare a knot. The first is how to prepare a knot. Second is how to through the knot. And the third is how to secure the knot, right? So you need a good knot, and it should be well secured so that your anastomose shouldn't leak, right? So it has got three components. So first is the preparing the knot, then throwing the knot, and the third is securing the knot, right? So the first and important portion is how to prepare the loop. So in this picture you can see, the first thing is you have to shorten the tail. If you keep the tail longer, then it will be problematic during knotting. So you have to shorten the tail, right? So you have to pull the thread so that the tail should be appropriate. It shouldn't be too small so that it can slip. It shouldn't be too long so that it can create problems during knotting, right? It should be of appropriate length. And then you have to take these parallel relationship between these two knots, these two threads, and then make a loop. if you are able to make this loop, this is the preparation of the loop. So the first step is this one, to shorten the length of the tail, and then parallel relationship between these two sutures, and then making a loop, this loop, right? Now you just have to put your this right hand instrument and grasp this tail, and then through the knot. So this is the first part. Now this is the second part. Okay, so you have to put your this right hand instrument or needle holder in this loop, inside this loop, and then this is the first through, clockwise first through, then the second clockwise through, because the first knot usually we take two throws, like a surgeon's knot. Because if we go for the one through, then there are chances that it will slip, or you will not be able to make a secure knot. So we give one through, then the second through, okay, and now we have to grasp this short tail with this right hand instrument. So this is the first step. So the first segment was preparation of the loop. Now we have to through the knot, first through and second through, and then you have to grasp and try to grasp the tail from the tip or near the tip. If you will like grasp it below or more length, then it will create problem during knotting. Okay, so one through, second through, and then grasping the this tail. So this is the second segment. All right. Now this is the third segment, how to secure the knot. So preparation of the loop, then second is throwing the knot, the third is how to secure the knot. So for securing the knot, you have to cross your hands, right? This right hand, this tail was here previously. Tail was here. So you have grasped this tail through this instrument and then cross your hand. And this grasper will go upstairs and this will come down. So now you can have a secure knot, right? So which we call reef knot if it is single, and we call it surgeon knot if it is double through, right? So crossing the hands are very important. Otherwise, you will have an insecure knot that we call granny knot. Okay, so you have to cross your hands. And what as we are doing during open surgery also, we have to cross the hands. Otherwise, the knot will not be secure. It will be a granny and it may get dislodged. So you have crossed the hands and now you can tight it, right? So you can secure it. Now again, as the first knot has been completed, now you have to repeat this maneuver again 2 to 3 times, right? In the same way. You have to prepare the loop, you have to through the knot, and you have to secure the knot again. So, and again it will be crossed. Now previously this tail was here after the first knot. Now it has gone to the opposite side. So every time, whenever you through a knot, the short end or a tail will move to the other side, right? So when we were doing the first knot, the tail was here, and when we completed that knot, the tail was here, right? Now again, as the second knot is completed, now the tail moved towards the same previous position. Now if you want to give the third knot, again the tail will come back to the downstairs. So every time the tail will move to the opposite side, right? So these are the common mistakes which we do during we may do during intercorporeal knotting. Long tail or loop is not parallel. Like if we leave long tail, then we might end up with this bow. When we tight it and this tail will not come out, then we might end up with this knot, or there'll be difficulty. So the tail size of the tail should be appropriate. It should not be too long. It should not be too small. If it will be small, it may slip. And it should be parallel, like this. The other instrument should be angulated this way. If both are in same direction, then there will be struggling during the knotting. So if the other one, like as it was discussed before, that the angulation, the triangulation should be more than 60 and it should be parallel. If the angle is short, in it you can see the angle is not more than 60, it's in the 60. So it will be very difficult to tie a knot. So the angulation should be more than 60, right? So these two are the common mistakes which can be seen during this knotting. And these are the different techniques which I told you and discussed you is expert C technique. There are two other techniques, smiley technique and gladiator technique. In smiley technique, when we are short of length of suture, like we have done 1 or 2 stitches and now the length is very short, then you can take help from the needle and hold the needle on the left side and then through the knot, then maneuver the thread. Then it will be helpful. This is smiley technique. When we use needle, usually in the first and second through we were using only the threads. But when we'll stitch 1 or 2, we'll give 1 stitch, then the length of the this thread will become smaller. Then you can take help from the needle to tie, right? That is a smiley technique. And this gladiator technique, in this gladiator technique, we open the jaws of the needle holder while knotting. Usually we close our jaw of the this needle holder stays closed when we take the loops or we through the knot, right? And there are chances in that technique, there are chances that the loop will fall down. When we take first loop and when we'll try to take the second loop, then what will happen? The one loop will fall down. So to counteract that, we use this gladiator technique. In gladiator technique, the jaw stays open, and then we take the throws, so it will not fall. And then we grasp this tail and then complete our knotting. Okay, if there's any question, you can practice now again. So if there's any question, you can ask. If there's any problem, if practically, if there will be any problem, we are there to help out you, and try to practice more and more. These 15 minutes are not enough. As Dr. Mumtaz told you, that 20 hours practice, more and more practice. You'll keep on practicing. These are not difficult things. It just require practice. These are not difficult things. Just require practice. It's like mechanics, right? You keep on doing it again and again, then it will be very easy. When we started learning our reef knot and surgeon knot by open technique, it was difficult initially. But when we start doing it again and again, it became our reflexes. So in this way, over here also the same principle is applied over here as well. So if you keep on practicing, then they'll become your reflexes. Then there'll be no problem to tie, to knot, to suture, to stitch. There'll be no problem. All right? I would like to show you and demonstrate also how to do this knotting. to do knotting, not how to pass the needle through the tissue. So this is the loop. The length, I can shorten the length a bit more. Now this loop is prepared. I've taken one through, I've taken another through. Now I'm moving towards the So now the tail was here before. Now I have to move towards the opposite side. To tighten it, you can again. So this is the securing, how to secure the knot. Now this, in the same way, we have to repeat the cycle again. Now the tail is here. And now I'm supposed to take only one through is good enough. Yeah, express C loop. So this is a square knot, right? So in this way, you have to apply 3 knots, and in this way the whole circle will be completed, right? So now you will be given again 30 minutes, 15 minutes for one candidate, and you can practice over the simulator. Okay? Thank you.
यहाँ से नहीं, ये यहाँ से डाला था सर
नहीं पड़ा ना, आप नहीं जा रहे
ये एक दफ़ा पोजीशन करके थोड़ा स्टैटिक करने की कोशिश, इसको एक दफ़ा अपनी पोजीशन बना के होल्ड करें, इसलिए इस हाथ को स्टैटिक करने की कोशिश करेंगे तो ये वाला हाथ उधर जाएगा, वो वाला हाथ नहीं, हेयर डबल सिंगल नहीं डबल, ये वाला हाथ उधर आएगा, मीडियम होल्डर यहाँ से एंटर, ये वाला हाथ उधर जाएगा।
एक काम करो, दूसरे का काम करो, मैं बता दूँगी। लॉटरी प्रैक्टिस कर लो अभी। लास्ट पैटर्न फिर 10 मिनट है अभी। हमारा 12 उसके अंदर टाइम जाएगा। पहले जो अभी से मतलब एटलीस्ट फ्यूचर हो गया लेफ्ट ऑर्डर भी सीधे Yes, well, technically, no, you're at work. तो हमारा बेड अकेले हमारा नहीं होगा। भाई ऐसा सामने अब तुम्हें अंदर डॉक्टर ने मुझे बताना चाहती हूँ ये इधर से उठाओ ये जो होल है नहीं आप किसी को लेगा इनसाइड सीट डाल नहीं ना तो ये इनसाइड तो हुआ ये सीट या अदर जो कैरी उसको तो इसलिए मैंने कहा इंस्टेड ऑफ ये पूरा टाइम में पहले नीडली कुछ जो अभी वाली स्किल है वो अभी वाली एक ये इसमें ना जूमिंग करने का बहुत हो रहा है ये कोई भी बराबर में कोने में लगा इसको लगाना ये देखिए ये बम्पर
Let's begin with our next session, which will focus on laparoscopic suturing on board. This session will be conducted by Professor Farhan Zahir. He is a prominent general surgeon a prominent laparoscopic general surgeon in Karachi. At present, he is the head of department at the largest colorectal unit in Pakistan. Please give a warm welcome to Professor Farhan Zahir.
Okay, my presentation would be continuation of what we have already learned in earlier sessions, and it is continuation of that. We have already learned about the handling of needles, and we have seen how knotting practice is done. And my session would be about tissue approximation and tissue handling. It was supposed to be done as a second step, but knotting practice was done earlier to that. So we are going to discuss about this at this session. Ideally, the suture length which is required for interrupted sutures is about 10 to 15 centimeters. If you take more than that, it becomes troublesome. It becomes difficult to handle. So there are certain principles in which are applied in tissue approximation. One of them is that the needle holder should be held parallel to the tissue in which suture has to be applied. The other one is that the needle has to follow the axial rotation of the needle holder. The third one is that the resetting of the needle, that is when the needle is grasped by assisting instrument and when it has to be transferred back to the needle holder, that is called resetting. That has to be done at the tissue level. It shouldn't be moved away from the tissue, and it should be done, resetting should be done at the tissue level. So these are the diagrams which will guide you how to approximate the tissue with the help of sutures on board. The first diagram shows that the needle holder is parallel to the tissue which is being held with the help of assisting instrument. It is slightly lifted. Needle is entering at 90 to 70 degrees from the tissue level. In the second diagram, you see that the needle is following the axial rotation of the needle holder. Third diagram shows that the needle is grasped at point B by the assisting instrument. Now fourth diagram shows the resetting of the needle with the help of needle holder at point C. This is done at the tissue level, not away from the tissue. The fifth table, we repeat all the sequence on the other side, lifting the tissue with the help of assisting instrument, aligning the needle holder with the tissue, passing the needle through the tissue, following axial rotation of the needle holder, and again grasping the needle through the assisting instrument. So these are all the steps, and these are the principles which should be followed when we are reapproximating the tissue. ये चला दिया, इसको चला दिया, excuse me. This is the video which shows how it is done practically. Needle is grasped by needle holder at point C. Tissue is displaced in order to create some space. Needle is entered at 90 to 70 degree from the tissue. Needle follows the curve, grasped by other instrument, resetting done, same technique is applied on the other side. And the aiding instrument, the assisting instrument now becomes a pivot. And prevents damage to the tissue by the thread. Next दिखाइए, next video. Please. This is another video showing the same process. Needle held at point C. Tissue is displaced with the help of assisting instrument. Angle of 70 to 90 degree is made. The needle is entered following axial rotation of the needle holder. Held at point B. Reset it again at tissue level. Again tissue is displaced and the sequence is repeated on the other side. The other instrument acts as fulcrum, acts as pivot to prevent damage to the tissue and pull the thread from the margins. So now we move on to the stations in order to perform this exercise. Okay? Move to the stations, please.
Our next session involves laparoscopic suturing on the bowel. This session will be conducted by Dr. Ghulam Murtaza. He is an illustrious general surgeon specialized in bariatric surgery with over 15 years of surgical expertise. His Dosti campaign is renowned for providing medical and surgical treatment for obesity at an economical cost. Please put your hands together for Dr. Ghulam Murtaza.
Thank you very much for the invitation. Presentation. Sorry. Right. So, without wasting time, can you hear me, everybody? Okay. Without wasting time, I will move forward towards the presentation. Right. So this was the question when I joined Dr. Mumtaz Mahar on the very first day. उन्होंने कहा suturing आती है laparoscopic? मैंने कहा नहीं. So कहते हैं, do you know of a surgeon who doesn't know how to suture? मैंने कहा नहीं. So this is so crucial. And अगर दूसरा मैं सवाल पूछूं आपसे कि how many times you opted for open approach, or you converted to open just because of the reason that you didn't know how to suture? Most of the times, yeah, many of the times. This is one of the reasons that we opt for open approach. So how to reach at this level? Number one, as Dr. Mumtaz said, he was, उन्होंने तो underestimate कर दिया कि 20 घंटे I practice is at least 100 hours. सर आते थे 10:30 बजे, मैं 9 बजे जाके practice करना शुरू करता था जब तक सर आ जाएं. So it was like at least 100 hours on the simulator. And then second thing is playing with the needle, with the tissues at a place जहाँ पे कोई आप उल्टा सीधा भी ले लें suture तो कोई उससे फ़र्क नहीं पड़ता है. That is TAPP. तो वहाँ पे फिर practice की. So inguinal hernia TAPP is a very good place where you can practice hand-eye coordination, everything. And then comes the laparoscopic appendectomy. तो उससे पहले laparoscopic appendectomy से पहले मैं ये करता था कि गॉल ब्लैडर में नीचे क्लिप्स लगा ली, ऊपर की तरफ मैं सिर्फ नॉट प्रैक्टिसिंग के लिए तो नॉट प्रैक्टिसिंग उस पर कर लेता था. उसी वक्त ही पता चल जाता था कि मेरी नॉट अगर सही है तो बाइल लीक नहीं होगा. तो इस तरह से आहिस्ता आहिस्ता हम ग्रेजुअली मूव फॉरवर्ड करेंगे. एंड देन सब टोटल कोलिसिस्टेक्टमी, सो क्लोजिंग द स्टम्प. तो उसमें भी अगर लीक होगा भी तो इतना डेंजरस नहीं होगा जितना कि बावल का लीक होगा, क्योंकि वहाँ पे ड्रेन है, किसी तरह से बंद हो जाता है. इस तरह से स्टेप वाइज वी कैन मूव अहेड reaching at the level of the laparoscopic bowel suturing. Right. So general principles are the same जो हम open में कर रहे होते हैं. It's the same. Everything is same. जो कि हम open में करते हैं. The general principles are the same. Adequate blood supply, orientation, and everything is same. Now, most important as far as laparoscopic is concerned is the ergonomics. जो सबसे पहला हमारा था ergonomics कि triangle हो 60 degrees की angles होंगी तो बहुत अच्छी आपकी knot tying होगी. So orient the bowel, adjust table height, ये important है. जैसे यहाँ पे issue आप लोगों का आ रहा है कि वो इसकी adjust नहीं हो पा रही है तो आपके कंधे दुख जाते हैं. अमूमन ऐसा होता है कि जब by the end of the bariatric surgery में GG anastomosis अगर आपका हाथ ऐसे है तो उसके बाद trapezius आपका बैठ जाता है बिल्कुल. It soars like anything. So अब एक और important चीज़ जो है ना वो needle holder है. कौन सा needle holder इस्तेमाल करें? So the needle holder that the surgeon is comfortable with, जो वो commonly use कर रहा होता है, that is, and the needle holder that allows maximum manipulation, flexibility to your hands. इसी तरह economy of movement. सुबह भी इसी चीज़ को हम urge करते हैं. Economy of speed in surgery is economy of movements. So there are several needle holders. Tip तकरीबन same होती है. It's about the handle. Now this handle adds ये जितने भी handles हैं आप इसमें देख रहे हैं there is a ratchet into it. तो जब तक आप उस ratchet को आप press नहीं करेंगे वो खुलेगा नहीं. So one maneuver more. और उसके साथ साथ आपको एक ख़ास एंगल पे आके उसको काम करना होगा वरना वो काम नहीं करेगा. उस तक पहुंचने के लिए फिर आपको अपना हाथ छोड़ना पड़ेगा. तो more I mean the maneuvers are more. There is less economy. ये जो रूटीन में हम यूज़ कर रहे होते हैं लेप्रोस्कोपिक में भी होता है जिसमें हम फिंगर ग्रिप जो होती है इसमें भी यही प्रॉब्लम है कि आप यू कैन मूव योर फिंगर्स मैक्सिमम अप टू दिस डिग्री 180 डिग्री. But this asculip, this one I routinely use, Dr. Mumtaz also uses this. This asculip is like 360 degree. You can hold it like this, you can hold it like this. You can just click once, it will hold the needle, click twice, it will release the needle. So you don't need to adjust a lot. So this asculip, this has a very fine tip and this allows us a very good flexibility in our hands. So the selection of the needle holder is very crucial for any anastomosis. Then sutures on the bowel. So round body as in open, needle size क्योंकि 23 to 31 आप easily ports से insert कर सकते हैं. उसके बाद फिर बहुत thick हो जाती है, diameter wide हो जाता है. So needle holding जैसे अभी हमने किया यहाँ पे practice कर रहे हैं tip of the needle holder. The needle should be held at the tip of the needle holder. Needle tip slightly angled forward ताकि आपकी angle tissue के क्योंकि हम 60 डिग्री पे काम कर रहे हैं अगर बिल्कुल 90 डिग्री पे होगी तो टिश्यूज़ के साथ एंगल नहीं बनेगी. तो स्लाइटली एंगल्ड फॉरवर्ड तो वो आपकी एंगल से ही बन जाएगी फिर. ठीक है. देन एज इन माय स्टेशंस रिवर्स किस तरह करना है, फॉरवर्ड किस तरह करना है क्योंकि सूचरिंग जब हो रही होती है तो यू नीड टू हैव कॉम्बिनेशन ऑफ फॉरवर्ड एज वेल एज रिवर्स नीड. सो अवॉइड टेकिंग पोस्टीरियर वॉल ऑफ द बावल. किस तरह से आप लिफ्ट करें टिश्यू को, बूजी डालते हैं हम जीजे में इस तरह से कर सकते हैं या प्रीवियस सूचर को आप उठा लें तो उससे यू कैन अवॉइड टेकिंग द पोस्टीरियर वॉल. एंड एंट्री एट 90 डिग्रीज जिस तरह से डॉक्टर फरहान ने आपको बताया कि 70 to 90 डिग्रीज पे आप एंट्री करें. अदरवाइज क्या होगा कि सिर्फ सिरोजा आ जाएगा. आपको एक क्विकली कैसे पता चल जाएगा कि मैंने एडिक्वेट लिया है या नहीं. If you can see through if you can see the needle through it, you are not having the adequate tissue. So see through हो तो reverse कर लें फिर दोबारा से आप. So go into the tissue, enter the tissue at 70 to 90 degrees while taking care of not to take the posterior wall. Then rotatory movements of the hands. So it's again the economy of movements. When you insert the needle, rather than pushing your needle holder, twist your wrist like this. Follow the curve जो डॉक्टर फरहान ने भी दिखाया, सबने सुबह से जो follow the curve of the needle as well as your wrist. Rotatory movements rather than pushing and pulling movements, right? So these are the some of the So avoid holding suture too tight to fracture it. यहाँ पे important चीज़ ये है कि जितने भी needle holders यहाँ पे रखे हुए हैं, they are almost out of order. Needle holder ऐसा होना चाहिए when you start closing it, तो before the first click उनकी jaws close होने चाहिए हैं, ताकि हम बार बार जब ये मैनिपुलेशन करते हैं needle suture को small कर रहे होते हैं, तो कितनी दफ़ा आप क्लिक 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 करते जाएंगे. So it should be before the first click, the jaws should, close. तो उस वक्त हमें पता चल जाता है कि मैंने सूचर को सही पकड़ा हुआ है. तो इस तरह फ्रैक्चर से हम प्रिवेंट कर सकते हैं. बाकी इंटरप्टेड, कंटिन्यूस, बार्ब, नॉन बार्ब कौन सा यूज़ करना चाहिए, इट्स ऑल योर ओन प्रैक्टिस. जिस तरह से सो मास्टर वन टेक्निक, वट एवर यू आर डूइंग इन ओपनिंग, मास्टर दैट टेक्निक इन द लेप्रोस्कोपिक एज वेल. तो कंटिन्यूस इसलिए हैंडी होती है कि बार बार सूचर नहीं करने, नॉट्स नहीं टाई करनी पड़ती, टाइम सेव हो जाता है इस तरह से. बट इट्स अप टू यू, जिस तरह से आप जिसमें सेफ समझे. बट फॉर द सेक ऑफ प्रैक्टिस हियर हम ये करेंगे कि पोस्टीरियर भी कंटिन्यूस लेंगे, इंटीरियर भी कंटिन्यूस लेंगे, ताकि सबको एक फील भी मिल जाए और बारी भी मिल जाए बावल एनास्टोमोसिस की, और क्विकली भी हो जाएगा इस तरह से. नाउ देयर आर 2 वीडियोज़ सिर्फ डिमॉन्स्ट्रेट कर रहे हैं इसमें कि किस तरह से हम सूचर्स को ले रहे होते हैं. ओके, सो इसमें आप देखें कि हम कर्व को यूज़ कर रहे हैं, एंड विद मिनिमम मैनूवर्स. जैसे ही उन्होंने नीडल इंसर्ट की यूजिंग द कर्व ऑफ द नीडल, एंड अब टाइट करना देखें किस तरह से एंगल से हम टाइट कर रहे हैं ये, विदाउट एनी अदर पर्सन. लेफ्ट साइड से आप देखें, मूव, जस्ट रोटेटरी मूवमेंट्स एंड यू आर रेडी फॉर द नेक्स्ट सूचर. सो मिनिमम मैनिपुलेशन, इकोनॉमी ऑफ मूवमेंट्स, स्पीड ऑफ सर्जरी हियर. ठीक है, तो आप भी जब करेंगे यहाँ पे तो सिमिलर, you insert the needle, enter the tissues using the curve of the needle and rotatory movements of your wrist. Come out and holding with another hand the Maryland, just rotate the Maryland. Rotate the Maryland. It will come out. The needle will come out. And then hold the needle, the needle with the needle holder for the next suture. अब interrupted की लगा लें. अब इंटरप्टेड में ये है कि आपकी बार बार नॉटिंग की प्रैक्टिस होती रहेगी, लेकिन फिर दूसरे को शायद बारी ना मिल पाए, इसलिए इन ऑर्डर टू हैव. सो द प्रिंसिपल्स आर सेम एज ओपन. सिर्फ यहाँ पे जो इम्पोर्टेंट चीज़ है वो फील, अर्गोनॉमिक्स, डेप्थ परसेप्शन, इन सब चीज़ों की यहाँ पे है. राइट, ठीक है. सो फॉर द सेक ऑफ प्रैक्टिस हम पोस्टीरियरली भी एंटीरियरली भी कंटिन्यूस सूचर्स लेंगे. ठीक है, थैंक यू वेरी मच.
Ladies and gentlemen, now I would request Professor Sajida Qureshi to come up on stage and award the participants and facilitators with certificates. Okay. Dr. Khurshid को भी बुला लो एक बार. I would like to call Dr. Khurshid Ahmed Samo to distribute certificates along with Professor Sajida Qureshi. Okay. Dr. Mujib Abbasi. Firstly, we will करें डॉक्टर खुर्शीद को आने दो. Ladies and gentlemen, our guest of honor for today has just arrived. Dr. Bilal Ahmed, Director DOTS. He has been extremely generous with us in organizing the workshops and live surgeries of COLOCON 2022. We are truly indebted to his generosity in this regard. To begin with the certificate distribution, we'll first present certificate to Dr. Saeed Ahmed. Next is Dr. Farhan Zahir. Dr. Ghulam Murtaza. Dr. Zahid Ali Mehman. Mr. Shahid Mahmood. Now I would like to present certificates to our participants by Professor Sajida Qureshi.
I'm so very grateful to our respected mentors for facilitating in today's workshop. Now, turn comes for our participants of today's workshop. First is Dr. Jahan Ara Hassan. She has come all the way from Mirpur, mashallah. Mirpur Mathilo. Next is Dr. Sobia Rafi. Dr. Hassan Shahab. He is mashallah post call and so energetic. Dr. Mehreen Ansari. Dr. Harim Hussain. Dr. Komal. Dr. Unaiza Iram. Dr. Hafiza Bushra. Dr. Kanhaiya Lal. He has also come from outside Karachi, so after. Dr. Farhan Ali. Dr. Sumla Salman. Dr. M. Yasin Anwar. Now I would like to request Professor Mujib Abbasi to distribute certificates to the participants. Dr. Kamal Sikandar. Dr. Zakia Madad Ali. Dr. Fatma Yusuf. Dr. Muhammad Tayyibul Hassan. Dr. Gul Naseeb Khan. He was the first guy to reach at 7 a.m. Dr. Bushra Javed. Dr. Lachpat Rathor. Dr. Yusra Riaz. Dr. Kamal Nisa. Dr. Sana Shahid. They are all observers. Dr. Sabah Nazir. Dr. M. Alimuddin. Dr. Khadija Anis. Dr. Ikra Anis Rajput. Ikra Anis Rajput. Dr. Muhammad Akil Azmi. Dr. Ayman Faruqi. Dr. Syed Abdul Rahman. Khatam, last. Dr. Sadia.
I am doing my job.
Ma'am, this is last. Dr. Bushra Khan. Thank you, guys.
Bushra Khan. बिलाल साहब देंगे बिलाल साहब देंगे सर आप करेंगे ना मैडम को शीट दे
Now the movement जो हम बहुत ज़्यादा अप्रिशिएट करते हैं, प्रोफेसर साजिदा कुरैशी ने हमें बहुत हेल्प आउट किया है, and she has been just a token of appreciation for Professor Sajida Qureshi. And a shield. Yeah. Now the जो होस्ट हैं जिनकी परमिसेस हमने यूज़ की हैं उनके लिए एक शील्ड है बिलाल साहब के लिए मैडम, आप अगर काइंडली Thank you very much. Professor Sajida Qureshi, please.
Okay, guys, thank you very much. I hope you all had a good time. So before we go on to the last session, we would just like 2 words with you. So in the morning, I had asked you regarding your expectations. We are almost done with the workshop except for 1 session left. So I would like anyone, any 2 or 3 of you who would tell us, give us the feedback regarding the workshop. Did you find it up to the expectations? Do you want anything to be changed? And were your expectations met at the end of the day or not? Anyone who would like to speak, or 2 or 3 of you? We would suggest any changes that you would like us to make in our future workshops. So can we start with Dr. Kanaya and then give mic to our colleague over there?
And mainly the time is very short.
Okay.
We can't do a procedure in 15 minutes.
Mhm.
Even we can't start. And we are also 2 candidates on 1
Mhm.
station. The shortage of time and some instruments are out of order.
So
That was the
the
main
instruments, what I understand, were working properly. The only thing was their maneuverability, which was a bit of a problem, what I saw on your station. As far as time is concerned, naturally, the idea is not for you people to complete the procedure as such, but to learn the basic method, how to do it. Naturally, you know, some people are fast, some are slow, some could pick things early, some would struggle a bit. Initially, all this happens. But the main purpose was to give you give you an idea what the basic principle is, and naturally you'll go back and practice it, so you learn a lot with practice. Having said that, we can look at increasing the time, like 15 minutes to 20 minutes in our future workshops. This is something that we need to sit and, you know, work out the time factor. Yes, that's point well taken. Dr. Sir? Okay, so you thought the time was not. But overall, did you people learn regarding the content? Did you people learn, or was it helpful? Was it not helpful? How do you feel about it? It was. Yes. Okay, right. So this is very important. Remember, at the end of the workshop, the idea, the objective is not to make you experts, but to impart the correct technique, methodology, and then you can go back and practice. Anyone else who would like to say something? From the resident side, R1s, R2, R3, R4s जो बैठे थे, who had attended this advanced laparoscopy workshop for the first time? Okay, can we have an feedback from you?
Madam, it was really helpful. The facilitators were friendly. They taught us in a very good environment. We enjoyed overall, learned the basic techniques, but of course the time should be increased, I think.
Okay, so that's like lots of people have said that the time needs to be increased, so we'll look into it. Yes, there's this lady at the end, please.
Were an issue since most of us are like what 5'1", 5'2", so the table height was very
So my dear, this we cannot predict unless we have now a pre-workshop form that would ask you what's your height and what's your weight. So this would be getting too much into it. So this is something that, you know, sometimes you work in an awkward situation, yes, but naturally you did not have your ergonomics right. But this, I think, it would be very difficult for us to do. Okay. So anything else? Yes? Yes, Harim.
Ma'am, I would like to suggest that before beginning the session individually for the practice session, if the instructor could be given 5 minutes separately to demonstrate it, because our instructor was doing that and it was very helpful for us. But it shortened the time at the end.
Yeah, it does.
But it was very helpful.
Yeah.
So if that could be...
So in our, I think, previously we used to do that, but today because of the short time and because They have squeezed in another 2 sessions for you, which we usually do not have in our workshop. And these are very, very informative, and I'm sure you'll feel really good after attending these 2 last sessions, which are usually not part of it. That is the reason we had cut down on the initial, but our usual workshops, we do demonstrate. So this is the reason this simulator over here is connected to the screen, because we demonstrate. Because we were struggling for the time, so we decided, since each of the station had 2 facilitators, so we left it to them to sort that issue out. So they were supposed to demonstrate where you were struggling, which you are telling me your facilitator did. So this is how it should be. That is the reason we had kept 1 facilitators on 2 stations rather than keeping 1 on 4 stations, so they can give you a hand-on experience as well.
Thank you, ma'am.
Is that it? Thank you very much, and wish you all the best. So the take-home message is, please go back and keep on practicing.
Dear participants, we have, since Professor Sajida Qureshi has to move for his own commitment, her own commitment, she is supposed to give away the award of best performer in the workshop. So that activity has been arranged in such a way that all facilitators will give her feedback, and she, being the chief facilitator, will then decide who should be the winner of that gift. I'm sure all of the participants have tried their best. It depends. Some people have done a little more. Some people have done, as I can see, there are a few who are residents. There are a few who are actually practicing surgeons. So there will be difference. But then in all, the best performance, the dedication and the commitment, जिसने कितनी शो की है, उसके लिए हम facilitators का एक consensus develop करेंगे, और जिसने बेस्ट परफॉर्म किया है उसको हम एक बुक जो है प्रेजेंट के तौर पे देंगे, कोलोकॉन के यादगार के तौर पे. तो उसके लिए मैं रिक्वेस्ट करूंगा कि फैसिलिटेटर्स मैडम के साथ एक छोटी सी कॉर्नर मीटिंग कर लें. Meanwhile, I feel sorry for the shortage of time, as everyone was saying, and I do feel that it's very short time. We may plan maybe next time a little longish session for more hands-on time practice के लिए, लेकिन इस दफ़ा हमने इसको पैक इसलिए करके रखा था कि हमें इनको स्टेपलर्स दिखाने थे, एनर्जी सोर्सेज दिखाने थे, और स्टेपलर्स के बारे में कुछ लोगों को तो बहुत पता होगा, और कुछ लोगों को जो कि नए हैं शायद उनको इतना आइडिया ना हो, तो उनको एक हैंड्स ऑन हम एक फील देना चाहते हैं कि कैसे कटर स्टेपलर यूज़ किया जाता है. तो इस वजह से उस एक्टिविटी के बढ़ने की वजह से हमने ये वाला टाइम थोड़ा सा स्क्वीज़ किया था, एंड सो उसके लिए आई एम सॉरी, बट नेक्स्ट टाइम वील टेक केयर ऑफ दैट. आई डू फील एवरीवन फील्स कि ये टाइम काफ़ी नहीं है, और ये टाइम वैसे भी काफ़ी नहीं है. मे बी हम 2 दिन भी ये एक्टिविटी को स्टेज करें तो शायद काफ़ी ना हो, because the real skill comes when you practice. And I feel that हमारे जो लेप्रो ट्रेनर बनाने वाले हमारे दोस्त हैं माजिद साहब, इनकी मार्केट बहुत ब्राइट है. जो भी लोग यहाँ से क्वालिफाई होके जाएंगे या सर्टिफाइड कोर्स करके जाएंगे, दे वुड एटलीस्ट हैव अ फील कि यार हमारे पास घर में ये डब्बा होना चाहिए खेलने के लिए. तो मैं उनसे रिक्वेस्ट करूँगा कि वो हमें अपना दोस्त समझ के सब्सिडाइज रेट्स पे हमें ये डब्बे दें, और ताकि हम अपनी प्रैक्टिस करें और उनको हमेशा याद रखें, और इवेंचुअली पेशेंट बेनिफिट हो. Right. So as we have taken the verbal feedback, like अभी जो सेशन हो रहा था कि वर्कशॉप कैसा लगा, क्या शॉर्टकमिंग्स हैं, क्या इम्प्रूवमेंट्स की गुंजाइश है, हमने एक फीडबैक फॉर्म डिवाइस किया हुआ है जो कि सर्कुलेट करेगा. प्लीज़ टेक योर 2 minutes to fill up that form as well. So I'm waiting for the announcement if the jury is done with the job. Contest is the real spirit. Winning, losing is part of game. And when two best players fight, like Argentina and France fights, they were both best. But you know, it is the luck the day when you perform better. So I really appreciate and congratulate all of you for being with us today. So as Madam has whispered in my ear, it is Mr. Farhan Ali, Dr. Farhan Ali, who has been the winner today. He's been given this laparoscopic book as a memorable gift from COLOCON. Facilitator and speaker, Mr. Shahid Mahmood. He comes all the way from Dubai, and please introduce him. Please.
Our last session for today will deal with the basic concepts and anatomy of GI staplers, their use and demonstration of endo staplers. This session will be conducted by Mr. Shahid Mahmood. He is a certified trainer for conducting advanced training on adaptation of minimally invasive surgical procedures. He has an extensive international experience of conducting scientific sessions, hands-on workshops, and live surgeries. Currently, he is working as CEO at Al Maqam, that is Clinical Education Solution and Service Provider in Dubai, UAE. Please put your hands together for Mr. Shahid Mahmood.
Few months back in last May, and I have acquired my own organization in Dubai, which is the Educational Services and Solution Facilitation. I am affiliated with the Sharjah Surgical University. Sharjah Surgical University has an ongoing educational process of doing educational activities from basic to intermediate and to advanced with live animals. So we teach every type of surgeries. We invite faculties from everywhere. I will be going to have introduced that kind of facilities here in Pakistan, and very soon we are planning to recruit some of the faculties from here, and then we will be going to open this channel and this platform for all Pakistani experts, students to come over there and to get these benefits. तो मेरा आज का सेशन थोड़ा सा हटके है. हम सुबह से मिनिमल इन्वेसिव और लेप्रोस्कोपी की बातें कर रहे हैं और सूचर्स की बातें कर रहे हैं. सूचर इज अवर, एक्चुअली आई कॉल इट आवर मदर, बिकॉज यहाँ से हम सर्जरी सीखते हैं. पहली चीज़ जो हमारे हाथ में जब सर्जरी सीखते हैं तो हमें सबसे पहले यही चीज़ जो हमारे हाथ में आती है और इसके ऊपर ही हम अपना सारा दारोमदार और जैसे कि आज तमाम सर्जनों ने सुबह से शाम तक यही कहा कि भाई सूचरिंग सूचरिंग सूचरिंग, एनीबडी हु इज नॉट डूइंग सूचरिंग इज हैविंग अ डिफिकल्टी। तो आप यकीन करें, जब मैंने लेप्रोस्कोपी सर्जरी शुरू की तो बहुत सारे लोगों ने लेप्रोस्कोपी में बहुत इंटरेस्ट दिया, एब्डोमिनल एक्सिस में बहुत इंटरेस्ट दिया, लेप्रोस्कोपिक टेक्निक्स में बहुत इंटरेस्ट दिया, सूचरिंग में इंटरेस्ट नहीं दिया। वो कहते हैं यार हम मास्टर हैं सूचरिंग के, सूचरिंग में आप लोग हमें क्या सिखाएंगे। मैं कभी भी कोई कोर्स लेके जाता सूचरिंग करने का तो वो कहते यार प्लीज छोड़ो, सूचरिंग में क्या, आप हमसे सीख लो क्या सीखना है। बट हम उन्हें कहते थे नहीं, आप लेप्रोस्कोपिक सूचरिंग की बात करें, हम कन्वेंशनल सूचरिंग की बात नहीं कर रहे। तो एक दौर ऐसा आ गया कि बैरियाट्रिक सर्जरी आ गई। जब बैरियाट्रिक सर्जरी आई तो आप लोगों को अच्छी तरह याद होगा कि इसमें एडजस्टेबल बैलून लगा करता था एसोफेगस के ऊपर, दैट वाज कॉल्ड गैस्ट्रिक बैलून। अब जब लोगों को ये मजा लगा बैरियाट्रिक का, लोगों ने बहुत पैसे कमाए, लोगों ने बहुत काम किया, बैंड तो लगा दिया लेकिन अब सूचरिंग नहीं आ रही, गैस्ट्रिक एनास्टोमोसिस नहीं कर पा रहे हैं, वहाँ परेशान हो रहे हैं, प्रोसीजर नहीं हो रहा। फिर कंपनीज ने एक डिवाइस निकाल दी ऑटोमेटिक टाइप की, वो एक नीडल से इस तरफ पास होती थी उस तरफ पास होती थी, तो लोग सूचरिंग कर लेते थे। तो बहरहाल वो बात सूचरिंग की अलग हो गई। लेकिन मैं जो आपसे आज डिस्कस करने जा रहा हूँ वो है स्टेपलिंग पार्ट। तो सूचरिंग के साथ साथ आप सब लोग, चूंकि हम सर्जरीज के साथ मुंसलिक हैं, तो स्टेपलर इज पार्ट ऑफ दैट एक्टिविटी। तो मेरे वहाँ पे प्रेजेंट करता हूँ। तो बेसिकली व्हाट इज द कॉन्सेप्ट एंड एनाटॉमी ऑफ स्टेपलर। हम सब लोग स्टेपलर यूज करते हैं और करेंगे इंशाल्लाह। आप लोग खासतौर पे जो हमारे आने वाले यंग सर्जन हैं, आप लोग हमारा फ्यूचर है, यू आर आवर नर्सरी, यू आर गोइंग टू एजुकेट यू, वी वुड लाइक टू स्पेंड मैक्सिमम टाइम विद यू एंड वी आर स्पेंडिंग मैक्सिमम टाइम विद यू एंड आई नो दैट यू पीपल आर हैविंग लॉट ऑफ इंटरेस्ट टुडे। मैंने आज देखा कि इतने यानी शौक से आप लोग सूचरिंग सीख रहे थे, बट अगेन स्टेपलिंग इज ऑल्सो पार्ट ऑफ दैट। ठीक है, तो हम देखते हैं कि हम स्टेपलिंग के बारे में कितना जानते हैं, कितना समझते हैं और हमें कितना मालूम होना चाहिए। मैं भी आपसे सीखता हूँ और आप मुझसे कुछ थोड़ी बहुत इंफॉर्मेशन लें और इसको देखते हैं कि स्टेपलिंग में हम इम्प्रूवमेंट क्या कर सकते हैं। तो कॉन्सेप्ट एनाटॉमी की जब हम बात करें तो हमें इसकी डेफिनेशन तो बहुत आसान है, आप सब लोगों को मालूम है, लेकिन फिर भी इट्स गुड फॉर ट्रांसैक्शन व्हेन वी वांट टू डू अ ट्रांसैक्शन ऑफ एनी organ for resection and creating anastomosis. Of course, these three are the main principles when we are doing stapling. And then it is already used in all type of surgeries. Of course, in gynecology, इसमें बहुत open, wider range है gynecology and urology, thoracic, pediatric. You name it, in every procedure we have stapling. Right or wrong, sir? So how many of you have an interaction with the stapler, any kind of stapler, skin stapler के अलावा? So काफी लोगों का stapler के साथ interaction है। तो ठीक है, फिर आप जिनका interaction नहीं आज उनको कराएंगे। इसके बाद मेरी हैंड ऑन है, हैंड ऑन के अंदर आपको तमाम स्टेपलर के पास लेके जाएंगे। तो इससे पहले थोड़ा सा हम साइंस की तरफ जाते हैं। एक साइंटिस्ट है जिन्होंने एसेप्टिक टेक्निक इंट्रोड्यूस की मेडिकल साइंस में, डॉक्टर विलियम हल्स्टेन। ये उनका प्रिंसिपल है जो आज भी हम फॉलो कर रहे हैं और लकीली ये एक ऐसी प्रिंसिपल है जो इतने साल गुजरने के बावजूद भी हम लोग चेंज नहीं की, लेकिन इसकी चेंज करने की जरूरत पेश नहीं आई क्योंकि ये बहुत ही इम्पोर्टेंट और बहुत डायनामिक किस्म की इंट्रोडक्शन है। क्या हम सोचते हैं जब हम स्विचिंग भी करते हैं या स्टेपलिंग भी करते हैं, तो इम्पोर्टेंट इज दैट नो टिश्यू टेंशन। अगर आप किसी को टेंशन देंगे तो वो निक्रोसिस भी करेगा, ब्लीड भी करेगा। हमारे साथ यहाँ बैरियाट्रिक सर्जन भी बैठे हैं और हमारे पास कुछ जनरल सर्जन भी बैठे हैं, वो भी इसको एक्सप्लेन कर सकेंगे। टिश्यू पे टेंशन दिए बिना हम स्टेपलर को यूज करते हैं। लीक प्रूफ एनास्टोमोसिस, तो लीक प्रूफ एनास्टोमोसिस चाहे वो सूचरिंग का हो वो स्टेपलिंग का हो, ये वेरी इंपॉर्टेंट। अदरवाइज फिर हमको मिडल ऑफ द नाइट आना पड़ेगा और उसके बारे में देखना पड़ेगा। और ये तो प्रोसीजर के दौरान भी होता है। आजकल हम देखते हैं कि लोग स्लीप एस्पेक्टिव भी करते हैं, तो उसमें एब्डोमिनल साइड लीड करी होती है, तो लोग या तो पॉटी यूज करते हैं या सूचरिंग यूज करते हैं। आपने देखा है गुड हेमोस्टेसिस, ऑफ कोर्स इट इज द मोस्ट इंपॉर्टेंट पार्ट बिकॉज इट डिपेंड्स अपॉन द पोस्ट ऑपरेटिव हीलिंग। अगर ये नहीं होगा तो हीलिंग प्रोसेस डिले हो जाएगा और उसमें डिफिकल्टी होगी। फाइनली एडिक्वेट ब्लड सप्लाई, एडिक्वेट ल्यूमेन। तो एडिक्वेट ल्यूमेन भी बहुत इंपॉर्टेंट है। अब हम अक्सर सुनते हैं कि हमने 33 और 34 मिलीमीटर का सर्कुलर स्टेपलर इस्तेमाल किया और एंड टू एंड एनाटोमी, लेकिन हम ये नहीं समझते कि 34 मिलीमीटर का स्टेपलर तो यूज कर लिया. What is about the lumen? What was the nice diameter? Actual बात तो वहाँ पे खत्म होती है जहाँ पे ल्यूमन क्रिएट हुआ. साइज ऑफ स्टेपलर पे कोई इम्पोर्टेंस नहीं जाती. चले आगे चलते हैं. तो ये अब सोचने की बात ये कि सब लोग सूचर्स जानते हैं, सब सूचरिंग करते हैं, हर जगह सूचर होता है. फिर स्टेपलर क्यों पैसे इतने ज़ाया करें हम, क्यों इसके लिए हम इतनी मदद करें. कभी हमें स्टेपलर मिल रहा है, कभी हमें स्टेपलर नहीं मिल रहा. एक्सपेंसिव भी बहुत है. कुछ पेशेंट खुद अफोर्ड करते हैं, कुछ हॉस्पिटल मंगाते हैं. बेरियाट्रिक सर्जरी में आपने देखा है कि मोस्टली पेशेंट खुद अफोर्ड करते हैं, लेकिन बेरियाट्रिक सर्जरी आजकल कोई भी ओपन नहीं करता. एक जमाना था कि कोलिस्टेक्टमी सारे ओपन करते थे, आज कौन करता है? कोई भी नहीं करता. तो स्टेपलर इज वाई इट्स इजी टू यूज, देयर इज अ कंसिस्टेंसी, स्पीड इज ऑफ कोर्स देयर. आप एक एनास्टोमोसिस करने लगे सूचर के साथ, उसमें कितना टाइम लगेगा? उसकी जगह पर 70, 75 या 90 मिलीमीटर का स्टेपलर लगाते तो कितना टाइम लगेगा? इट्स वेरी फास्ट. देन स्टेपलर में एक बेनिफिट होता है कि some have simultaneous effect between 2 or 3 rows, set of double rows of staple line. It creates anastomosis in difficult cases. Enable skills depend upon the surgeon to carry out minimal invasive procedure. तो of course ये पार्ट तो बहुत इम्पोर्टेंट और इसीलिए हम सब यहाँ जमा किए हुए हैं कि हम इसकी स्किल को इसमें अपनी डेवलपमेंट करें ताकि जब हमें जरूरत पड़े तो वी कैन यूज द राइट टाइप ऑफ स्टेपलर. जब स्टेपलर में चले जाए हम तो हमारे पास दो टाइप के स्टेपलर होते हैं. वन इज द ओपन स्टेपलिंग टेक्निक, अनदर वन इज लेप्रोस्कोपिक स्टेपलर. तो ओपन स्टेपलर लेप्रोस्कोपी में यूज नहीं होता अनलेस एंड अदरवाइज आप कहीं कोई हैंड असिस्टेंट लेप्रोस्कोपी कर रहे हैं तो वहां पे कोई स्टेपलर ओपन सर्जरी का वहां पे यूज रहता है. लेकिन लेप्रोस्कोपिक स्टेपलर एंड ओपन स्टेपलर आर कंप्लीटली डिफरेंट. The science and technique is same. उसमें क्या है, इसमें आप देख रहे हैं कि इसमें आपके पास एक तो लीनियर स्टेपलर होता है. Anybody can tell me anything about दो लाइन में लीनियर स्टेपलर? What does it mean? It has a knife or it doesn't have a knife? Somebody can tell me. Linear stapler has a knife or it cuts or it doesn't cut?
No, it doesn't.
It doesn't cut. It's only stapler. Then we have linear cutter. What about this? It has a knife? Absolutely, it has a knife. So the difference between the job of this thing and the job of this thing, it can create an anastomosis, but it can cut in between. It can give a staple line on the patient side, and it can give a staple line on the specimen side, and cut in between. This can give only cutting line, right? उसके बाद हमारे पास ये कंटूर है. अब कंटूर इसका हेड जो है कर्व होता है. ये कर्व क्यों बनाया? इसलिए बनाया कि जब कोलोरेक्टल सर्जन LAR करते हैं, लो एंटीरियर रिसेक्शन करते हैं, जब वो डीप डाउन रेक्टम में जाते हैं तो रेक्टम इज वेरी टाइट, स्पेशली इन मेल रेक्टम. दे कैन नॉट रीच टू द पॉइंट वेयर दे वांट टू डू द ट्रांसेक्शन. तो ये कर्व जो होता है ये बेसिकली 40 मिलीमीटर का होता है. ये 30 मिलीमीटर के एंगल में इसको कन्वर्ट करके कर्व बनाया गया है ताकि ये डीप डाउन इन दी पेल्विक जा सके और वहां पे जाके ये रिसेक्शन एंड ट्रांसेक्शन कर सके. Finally, my loved one, I like this device. This is a circular stapler. इससे बेहतरीन स्टेपलर आज तक दुनिया में बना नहीं है और ना बनेगा. ये बेहतरीन है लेकिन बहुत खतरनाक है. इसको इस्तेमाल करना भी बहुत इसकी टेक्निक है. It's just one fire, and if there is a wrong fire, then patient goes for the whole life. और आपको पता है कि वो उस पर नहीं रहेगा, नॉर्मल लाइफ में नहीं रहेगा. फिर उसके लिए आप वो बैग लगाएंगे, ठीक है ना? तो that will be a difficult situation. तो रिपेयरेबल नहीं है. चले, ये बहुत इंटरेस्टिंग है. अगेन दिस इज माय सेकंड लव. एंडोस्टेपलर. हर जगह एंडोस्टेपलर लग रहा है, चाहे गायनेकोलॉजी है, चाहे जनरल सर्जरी है, चाहे कोई भी प्रोसीजर. इसमें भी डिफरेंट टाइप के स्टेपलर्स हैं. आजकल वो कुछ स्टेपलर आर्टिकुलेशन जॉइंट के साथ आ रहे हैं. कुछ पहले जब इंट्रोड्यूस हुए थे तो वो स्ट्रेट थे, फिर आर्टिकुलेटिंग आए. उसके बाद अब जो आ रहे हैं, जो हम मार्केट कर रहे हैं, उसमें बैटरी लगी हुई है. तो वो बैटरी के साथ फायर किए जाते हैं. एक बार आप बटन फायर कर दे तो फायर करता है. So these are the open and laparoscopic stapler which you are going to see on the table, and we are going to give you in your hand, and you will be going to fire them, and you are going to challenge us, and we are going to challenge you over that station, right? So I want to pass on here fast so that we can discuss there. Right. फिर हम आ जाते हैं वापिस जहाँ से मैंने स्टार्ट किया था कि एनाटॉमी ऑफ स्टेपल का स्टेपल हम सब जानते हैं, हम सब ने यूज किया, लेकिन एनाटॉमी ऑफ स्टेपल हकीकत में है क्या, इसके अंदर जादू क्या है, इसके अंदर चीज क्या है, जो स्टेपल है वो क्या करते हैं। होता यह है कि स्टेपल मुख्तलिफ किस्म के हैं, इसमें 2 लाइन ऑफ स्टेपल्स भी होती हैं, इसमें 3 लाइन ऑफ स्टेपलर्स भी होती हैं, इसमें 6 लाइन ऑफ स्टेपलर भी होती है। तो 3 लाइन ऑफ स्टेपलर एक स्टेपलर में होते हैं, 6 लाइन वो होती है जो 3 लाइन स्पेसिमेन साइड में होती है, 3 लाइन पेशेंट साइड में होती है, और उसके बीच में एक कटर होता है, जैसे मैं यहाँ पे दिखा रहा हूँ आपको। ये सिंपल स्टेपलर है, ये 3 लाइन का स्टेपलर है, ये एक कटर स्टेपलर है। इसके आप देख रहे हैं इस साइड पे स्टेपल लाइन है, इस साइड पे स्टेपल लाइन है, और ये बीच में एक लाइन है, दिस इज कॉल्ड द कट लाइन। So this goes to the patient side, this goes to the specimen side. This we have to cut manually by our code line. लेकिन आप ये देख रहे हैं कि इसकी जो स्टेपल रोज है ये स्टेगर्ड है, इस रो ने इसको कवर किया और इसको कवर किया, फिर इस रो ने इसको कवर किया और इसको कवर किया, ताकि जब स्टेपल हो जाए तो उसमें लीकेज ना हो। ठीक है ना, बात समझ में आ रही। तो दिस इज कॉल्ड स्टेगर्ड स्टेपल लाइन। इसको थोड़ा सा मैंने और एलेबोरेट किया है दिखाने के लिए कि अगर हम कोई भी लेंथ स्टेपलर की लेते हैं, फॉर एग्जांपल 75 मिलीमीटर के हमने स्टेपलर का नाम सुना, हमने 65 का सुना, हमने 35 का सुना, हम अलग अलग साइजेस का नाम सुनते हैं। वो स्टेपल लाइन तो प्रॉक्सिमल से डिस्टल ये स्टेपल को देंगे, लेकिन कट लाइन जो होगी, हाउ मच शुड बी दैट, हु कैन टेल मी? सपोज इफ वी आर यूजिंग एन स्टेपलर और अ कटर ऑफ 75 millimeter staple line, what do you think about the cut line? It should be 75 millimeter, or should pass the staple line, or should not pass the staple line? It should not pass the staple line, because आपको 2 या 3 मिलीमीटर जो है वो एडवांस स्टेपल लाइन देनी है, ताकि अगर आपको सेकंड स्टेपल लाइन यूज करनी है तो आप उससे पहले वो लीकेज ना करें। सो स्टेपल लाइन स्टॉप्स बिफोर एटलीस्ट 3 millimeter before the staple line. Am I clear in my talk? Quick question, quick clarification, any doubt? Okay. So ये शेप है, अलग अलग शेप है, ठीक है ना? Anyone who can tell me about this one? What stapler is this? This is used for what kind of anastomosis? End-to-end anastomosis. Okay, end-to-end anastomosis. Like what procedure? Like NAR procedure. Absolutely right. Right? And then कभी-कभी कुछ लोगों ने इसको गैस्ट्रिक बैंड में भी यूज किया, एसोफेगस के लिए उसमें बैंड लगाने के लिए। Who can tell me about this kind of stapler? ये क्या है? Cloud stapler. And where it can be used? For the rectum in the deep pelvis, where normal stapler cannot reach. तो ये बीच में क्या है? लेकिन यहाँ आप देख रहे हैं कि ये स्टेपल लाइन के बीच में नहीं है, लेकिन बाहर है, बिकॉज वी आर क्रिएटिंग ल्यूमन हियर। यहाँ पे ल्यूमन क्रिएट हो रहा है, वहां पे ल्यूमन क्रिएट नहीं हो रहा है। ठीक होगी बात समझ में आ रही? चल, इसके अलावा ये जो है ये वो हमारे नॉर्मल है। आप देखिए यहाँ पे 3 रोज है, इसमें 2 रोज है, ये सिर्फ स्टेपल। तो कुछ स्टेपल हमारे पास 3 रोज के आते हैं, दे वांट टू हैव बेटर एनास्टोमोसिस, दे वुड लाइक टू हैव 3 स्टेपल रोज, करेक्ट? चलिए अब आइए एनाटॉमी। होता क्या है ये स्टेपल? आप देख रहे हैं ये स्टेपल इस तरह से होता है। नॉर्मली मैं अपनी फिंगर से डिजाइन करता हूँ, ये इसका क्राउन है और ये लेग है, ठीक है। हर स्टेपल इस तरीके से होता है जो हम ऑफिस पे यूज करते हैं। जब हम स्टेपल लगाते हैं उसमें तो वो उसकी ओपन लेग होती है, जब उसको पेपर पर रखते हैं क्लोज करते हैं तो वो क्लोज हो जाता है। तो वो जो लेग है ना, ये अब अगर मैं ये 5 उंगलियां खड़ी कर दूं इस तरह से, तो ये क्राउन है, लेकिन ये 5 उंगलियों की लेंथ अलग अलग है। दिस इज व्हाट आई वांट टू एक्सप्लेन इन माय नेक्स्ट स्लाइड। तो पहली बात आप समझ जाइए, यहाँ पे ये तो क्राउन हो गया, ये इसके लेग है, और जब हम इसको फ्लाई करते हैं तो इस तरह की ये बी फॉर्मेशन होती है। ये बी फॉर्मेशन क्यों इंपॉर्टेंट है, और ये बीच में ये जो मैंने एरो बनाया है, व्हाट डज इट इफेक्ट, व्हाट डज इट रिप्रेजेंट? एनी आइडिया? डायमीटर ऑफ it is the thickness of the tissue which you are trying to anastomose. इसके बीच में आप टिश्यू ले रहे हैं, इसलिए आप सेलेक्ट करते हैं। आप कभी वार्ड में गए होंगे, खासतौर पे पेडियाट्रिक सर्जन कभी अपनी नर्स को ये कहते हैं कि मुझे ग्रीन रोक दो, मुझे व्हाइट रिलोड दो, मुझे ब्लू रिलोड दो, मुझे गोल्ड रिलोड दो। कोई आइडिया है कि वो ग्रीन ब्लू व्हाइट क्यों है? उसकी ओपन लेग लेंथ है, क्लोज लेग लेंथ अलग अलग। ठीक हो गया। और वो अकॉर्डिंग टू टिश्यू थिकनेस इस्तेमाल की जाती है। मैं आगे आपको उसको उसका कोई आइडिया दे रहा हूँ। अब ये ओपन लेग लेंथ है हमारे नॉर्मल स्टेपल्स के। आप ये देख रहे हैं, मैंने यहाँ ओपन लेग लेंथ रखा। ये कलर ग्रीन का ओपन लेग लेंथ 4.1 से लेकर 4.8 तक होती है, ठीक होता है। फिर गोल्ड है, फिर ब्लू है, फिर व्हाइट है। यू कैन गेट दिस चार्ट, देयर इज नो इशू, दिस आर अवेलेबल एनीवेयर। ठीक है, ये ओपन हर जगह स्टैंडर्ड है। इसके बाद ये क्लोज है। जब हम इसको फायर करते हैं तो वो हर ओपन लेग लेंथ इस काइंड की बी फॉर्मेशन करता है। दिस इज वेरी इंपॉर्टेंट। अगर आप इसको सिलेक्ट नहीं करेंगे, इस तरह से राइट सिलेक्शन नहीं करेंगे तो नेक्रोसिस होगा या लीकेज होगा। Am I right? ओके। आपने सुना है, अभी ये मैंने बात की है कि सर्जन मानते हैं, कभी व्हाइट मानते हैं, ब्लू मानते हैं, गोल्ड मानते हैं, ग्रीन मानते हैं। ये इनकी मैंने साथ में इलस्ट्रेशन दी हुई है। तो व्हाइट जो है उसकी ओपन लेग लेंथ जो है 2.5 है और उसकी क्लोज लेंथ जो है 1 मिलीमीटर। अब व्हाइट वाला नॉर्मली किस टाइप के टिश्यूज में यूज होता है? एनी आइडिया? वेसल्स पे यूज होता है। वेसल, फॉर एग्जांपल, अगर व्हाइट को आपने स्टमक के पायलोरस पे यूज करना हो तो आप करेंगे? कभी भी नहीं करेंगे, क्योंकि स्टमक का पायलोरस तो बहुत थिक है, उसको अकोमोडेट नहीं कर पाएगा। राइट? तो अगर आपने व्हाइट यूज कर दिया तो क्या होगा? नेक्रोसिस हो जाएगा, ब्लड सप्लाई नहीं होगी, ये दुनिया के मसाइल होंगे और फिर उसके बाद आपके साथ मसाइल होंगे, आपको आना पड़ेगा। ठीक है, ये फिर से एक छोटी सी आइडिया है कि कुछ स्टेपर हमारे पास ऐसे होते हैं जिनको हम एडजस्ट करते हैं ड्यूरिंग द प्रोसीजर अकॉर्डिंग टू द टिश्यू थिकनेस। हम फील करते हैं, हमारे सर्जन फील करते हैं कि कहाँ पे हमें इसको फायर करना है। तो वो जो होते हैं वेरिएबल एडजस्टेबल हाइट होते हैं, कुछ हमारे पास फिक्स होते हैं, उनको हम चेंज नहीं कर सकते, वो आइडेंटिकल होते हैं। अगर आपको वेरिएबल एडजस्टेबल हाइट का स्टेपर कोई मिले तो वो मेनली सर्कुलर में होता है, जो भी आपको दिखाएंगे हम। उसमें एडजस्टेबल होता है कि वो टिश्यू की थिकनेस को रीड कर लेता है। अब एक और कहानी है इसके बाद। ही तो हो गया आपको 3-4 बातें, एक तो कॉन्सेप्ट हुआ, उसके बाद आपके पास एनाटॉमी है। अब हम आते हैं, ये लीकेज क्यों होता है, ये ऊजिंग क्यों हो जाती है स्टेपल में, ये स्टेपल फायर क्यों नहीं सही होता। जब मैं स्टेपल फायर करता हूं तो उसके लेग जो है वो पूरी तरह बी क्यों नहीं फॉर्म करते। ये बहुत सारी बात है। इसके लिए मुझे पूरा एक दिन चाहिए। इसको हम साइंस ऑफ टिश्यू मैनेजमेंट कहते हैं, साइंस ऑफ स्टेपलिंग मैनेजमेंट कहते हैं। इट्स एन इंटरेक्शन बिटवीन द सर्जन, डिवाइस एंड द टिश्यू। तो इसमें ये बहुत लंबा चौड़ा प्रोग्राम है, लेकिन मैं इतना टाइम नहीं दे सकता यहाँ। बहरहाल तो थोड़ा सा डिस्कस करते हैं। ये क्या है, ये स्टेपल साइज इज इम्पोर्टेंट इन अचीविंग ऑप्टिमल कंप्रेशन एंड हीलिंग। अगर आप स्टेपल कार्ट्रिज यूज नहीं करेंगे आपको राइट ऑप्टिमल हीलिंग नहीं मिलेगी, आपको एनास्टोमोसिस करेक्ट नहीं मिलेगा। am I right? आप ब्लू की जगह रेड यूज कर सकती हैं? नहीं कर सकते। तो दैट मीन दैट यू आर सिलेक्टिंग ए राइट फॉर एन ऑप्टिमल कंप्रेशन। ठीक है ना? इसी वजह से फिर आपको वो स्टेपल राइट मिलेगा, क्योंकि हर टिश्यू अलग है। स्टमक अलग है, लंग अलग है, स्मॉल इंटेस्टाइन अलग है, लार्ज इंटेस्टाइन अलग है, सिग्मॉइड कोलन अलग है, यूट्रस अलग है, फैलोपियन ट्यूब अलग है, ओवरीज अलग है। आप एक स्टेपल तो हर जगह यूज नहीं कर सकते। हर एक की टिश्यू थिकनेस अलग है, हर एक की कंप्रेसिबिलिटी अलग है, हर एक के अंदर फ्लूइड अलग है। अगर आप लंग को प्रेस करें तो उसके अंदर कितनी एयर होती है। आप एयर को बाहर निकाल के स्टेपल करेंगे ना, कि आपने ढक से रखा, आपको मैं गुब्बारा दे दूं और तो गुब्बारे को मैं उनको बीच में से कंप्रेस कर दूं, तो आप उसको बीच में ढक करेंगे, फट जाएगा। लेकिन अगर मैं आपसे कहूँ यार देखो इसको जेंटली करो, तो आप उसको 2 हिस्सों में डिवाइड कर लोगे ना, ऊपर वाला हिस्सा अलग हो जाएगा, नीचे वाला हिस्सा उसको कंप्रेस। तो कंप्रेसिबिलिटी ऑफ हर ऑर्गन इज डिफरेंट बिकॉज ऑफ द फ्लूइड। हर ऑर्गन में फ्लूइड होता है, स्टमक में भी होता है। इसलिए कंप्रेसिबिलिटी जो इम्पोर्टेंट है, वो कंप्रेसिबिलिटी कौन करता है। जैसे हम घर कहीं जाते हैं वेकेशन पे, तो मैडम कहती है यार ये बैग बंद नहीं हो रहा है, इसको आके बंद करो। वो छोटे बेटे को बुलाती है, वो खड़ा होता है, फिर भी नहीं बंद होता, क्योंकि उसने सामान इतना भर दिया होता है। फिर वो मुझे बुलाती, भाई आके इस पे खड़े हो, मैं इसे बंद करूँ, तो मैं ऊपर आके खड़ा होता हूँ, यहाँ बैठता हूँ, तो वो बंद हो। कंप्रेसिबिलिटी बड़ी इंपॉर्टेंट। इसी तरह ये जो स्टेपलर है, अगर आप इसका एनुअल स्ट्रॉन्ग नहीं लेंगे, जो स्टेपलर स्ट्रॉन्ग नहीं होगा, ये उस ऑर्गन को कंप्रेस नहीं करेगा और उसके अंदर से ड्रेन नहीं करेगा, और एट द एंड ऑफ द डे वो स्टेपल की सही बी फॉर्मेशन नहीं होगी, प्रॉक्सिमल साइड पे अच्छा बी बनेगा, डिस्टल साइड पे अच्छा बी नहीं बनेगा। तो डिस्टल साइड का बी जहाँ पे नहीं अच्छा बना वहाँ पे क्या होगा, व्हाटएवर काउंट 100 प्रॉब्लम। तो होता क्या है, स्टेपल की कॉन्सेप्ट ये है कि आप ये देख लीजिए ड्राइवर्स बीच में बनाए होते हैं, ये ऊपर का हिस्सा एंगल है स्टेपल का, ऊपर का हिस्सा, ये नीचे का हिस्सा हुआ है जहाँ पे कार्ट्रिज बेस की जाती है, इसके अंदर ये ड्राइवर होते हैं। जब हम यहाँ से पुश करते हैं तो ये ड्राइवर स्टेपल को मूव करते हैं और ये स्टेपल इन पॉकेट्स में जाता है। जब इन पॉकेट्स में जाता है उसके बीच में ये एरिया जो है ये टिश्यू का एरिया है, बीच में टिश्यू है ये पिंक कलर का, ये ड्राइवर जा रहे हैं और यहाँ पे भी देखें आप, ये तो आइडियल सिचुएशन है, यहाँ पे देखिए ये बी फॉर्म हो रहा है, जैसे जैसे आगे बढ़ रहा है स्टेपल बी फॉर्म करता हुआ जा रहा है और ये अभी बी फॉर्म नहीं हुई, लेकिन इसका लाइन ऊपर गया, इसका लाइन ऊपर गया, टर्न किया इसने और इसने इसको आगे बी फॉर्म बना दिया। लेकिन किसी किसी जगह पे जाके ये चीज होती है, ये बी बनती है, ये चीज होती है, ये चीज होती है, दिस इज द प्रॉब्लम। और ये होता है बिकॉज वी डोंट नीड सेलेक्ट द राइट स्टेपलर फॉर द राइट टिश्यू, or our stapler is not compressing that tissue that much we require. Am I right? जहाँ तक कोई क्वेश्चन है, कोई चैलेंज है मेरे लिए, कोई बात समझते हैं कि आप गलत है यहाँ पे, तो आप बताइए, सही कर देते हैं। Everything is fine? Okay, that's it. इसकी मिसाल ले लें आप, इसकी मिसाल बहुत इंपॉर्टेंट है, ये हमारा इंपॉर्टेंट ऑर्गन है, हमारा सबसे बड़ा रिजर्वर है। यहाँ पे आप देखें हम स्टमक को कैसे देखते हैं, ये हमारा पाइलोरिक एंट्रम है, ये हमारा कार्डियक नॉच है, ठीक है, दिस इज लेसर कर्वेचर एंड दिस इज आवर ग्रेटर कर्वेचर, इन बिटवीन वी हैव द बॉडी। तो लेसर कर्वेचर साइड इज rather thinner than the greater curvature. The tissues are more thicker over the greater curvature side, but lesser on the thinner on the lesser curvature side. इसी तरह पाइलोरिक में थिक टिश्यू है, कार्डियक नॉच में थिन टिश्यू है। ये रफली कैलकुलेटेड फिगर है फॉर अराउंड 1700 पेशेंट बैक इन लाइक 5-10 years बैक इन यूएस, उन्होंने 20 पेशेंट को सर्वे करके ये निकाला था। तो आप मुझे बताएं, अगर आपको कार्टिलेज यूज करना पड़ जाए इस थिकनेस के ऊपर, क्या कोई व्हाइट लगाएगा पाइलोरिक में? ब्लू भी कोई रिस्क नहीं लेगा, तो कौन क्या लगा देगा? ग्रीन लगा देगा, ताकि यहाँ पे ये देखो, ठीक हो क्या ना? ये आइडिया मैं इसलिए यहाँ पे इसी मैंने ये भी रखा है कि अगर लंग्स में हो तो वो भी अलग अलग है, इंटेस्टाइन है तो वो भी अलग है। तो यू हैव टू अंडरस्टैंड एंड यू हैव टू रीड। इसके ऊपर बहुत सारी क्लासेस होती हैं, इसमें बहुत सारे डिस्कशन है जो मैं यहाँ इस पैनल में नहीं कर सकता। यहाँ देख लें आप, पेडियाट्रिक सर्जरी, कोलो, एब्डोमिनल सर्जरी, जनरल सर्जरी, गायनी, सबका एक ही कॉन्सेप्ट है, टिश्यू थिकनेस, इसकी टिश्यू थिकनेस, कोलन की, हर चीज के अलग अलग टिश्यू थिकनेस है, उसके हिसाब से आप रीलोड या स्टेपलर चूज करते हैं, राइट सर? ये एक ऐसा चार्ट है जिसको हम हमेशा अपने पास रखते हैं, ध्यान में बिठाते हैं, कौन सा रीलोड हमें किस टाइप के टिश्यू पे यूज करना है, और जब करेंगे तो उसकी बी किस तरह की फॉर्म होगी, और वो बी फॉर्म करेगी तो क्या होगी, वो सही भी बनेगी या चैलेंजिंग भी बनेगी या लीक भी बनेगी या नेक्रोसिस भी बनेगी। सो दिस इज एन आइडियल चार्ट अबाउट दैट। फाइनली हमें जो टेक बैक होम मैसेज है इस स्लाइड के ऊपर वो ये है कि हमें जब भी कोई स्टेपलिंग करनी है तो हमें यही याद रखना है कि टिश्यू थिकनेस हर ऑर्गन की अलग है, पेशेंट टू पेशेंट भी अलग है। कुछ बीएमआई लो बीएमआई के हैं, आजकल 45 बीएमआई के पेशेंट भी आ रहे हैं, उनको उठा कर आना पड़ता है क्रेन के साथ। तो कुछ ऐसी कुछ नॉर्मल स्किनी भी है, तो हर एक के साथ हम एक जैसा बर्ताव नहीं कर सकते। कंप्रेसिबिलिटी मैंने पहले से बता दी, फिर से रिपीट कर रहा हूँ कि हर एक के अंदर अलग टाइप का फ्लूइड होता है, उसके हिसाब से उसको कंप्रेस किया जाता है। और प्रॉपर्टी ऑफ वेरिएबिलिटी, पेशेंट, हर पेशेंट अलग अलग है, कोई किसी का कैंसर, किसी का नॉर्मल वर्जन ऑर्गन है, वहां पे अलग अलग सिचुएशन होती है। इसके बाद सबसे इंपॉर्टेंट बात होती है हमारे टिश्यू की। हमारा टिश्यू एक तकिए की तरह है, जब हम उसके ऊपर हाथ रखते हैं वो तकिया बैठ जाता है और वो मेरी 5 उंगलियों के निशान बन जाएंगे। मैं रात को सोने जाता हूँ तो सर के नीचे तकिया रखता हूँ, वो तकिया मेरी ये गर्दन का कर्व बना के उसको एडजस्ट करके मुझे सुकून से नींद आ जाती है। जब मैं उठता तो तकिया वापस अपनी जगह आ जाता है। इसी तरह हमारे ऑर्गन है, उनके बाइफेसिस नेचर है। उनकी शेप ओरिजिनल शेप में वो वापस आना चाहते हैं, आप स्टेपल लगा दें, आप सूचर लगा दें, वो कोशिश करेगा कि मेरी जगह वापस मुझे मिले, वो पुश बैक करेगा। बाद औक़ात ऑर्गन स्टेपलर को पुश बैक करते हैं। अगर वो स्टेपलर अच्छी क्वालिटी का नहीं लगाया, अच्छी जो कि मेडिकल साइंस के रिकमेंडेशन के हिसाब से उस कैपेसिटी का वो स्टेपल नहीं बना हुआ, तो वो स्टेपल क्या करता है, वो स्टेपल जर्क करता है। जब वो जर्क करता है तो मिडल ऑफ द नाइट बुल खुल जाता है। जब वो खुल जाता है तो आपको बुलाया जाता है। जब आपको बुलाया जाए तो आप वैस्कुलर सर्जन को बुलाते हैं। उसके बाद फिर कहानी लंबी होती है, फिर इन्वेस्टिगेशन होती है, फिर बुला होती है, ठीक है ना। तो एक वो स्टेपल जो है वो आपको बड़े सोच समझ के चूज करना है। इसीलिए पैसे तो खर्च होते हैं, जब आप अच्छी चीज लेंगे तो उसके लिए महंगा स्टेपल तो लेना पड़ेगा। तो tissue have bifacial nature, as a result it has a viscoelastic response. Viscoelastic response मैंने बताया आपको, आप प्रेस करें थोड़ी देर के लिए किसी ऑर्गन को छोड़े, वो अपनी जगह पे आए, ऐसे ही है ना, अपनी जगह फिर वापस। Take home messages: an appropriate staple, administrative application, managing, using, controlling, reading, optical anesthesia, part of healing and recovery. ये वो वर्ड है जो हम सब मानते हैं, लेकिन इसके लिए हमें प्रॉपर स्टेपल का सिलेक्शन करना इम्पोर्टेंट है। स्किल बड़ी इंपॉर्टेंट है, उसको समझना बड़ा इंपॉर्टेंट है। एक बार मेरे साथ ऐसा हो गया सर्जरी, आई वाज इन द सर्जरी डूइंग स्लीप टेस्ट। मेरे बहुत अजीज लोग डॉक्टर समूह जैसे लोग, मैं हमेशा मेरी आधी लाइफ OR में गुजरी। मैं सुबह 6 बजे जाके शाम 6 बजे तक OR में गुजारता हूँ, उनके साथ काम करता हूँ, कोशिश करता हूँ, अपने डिवाइस दिखाता हूँ। स्लीप टेस्ट भी कर रहे थे वो डॉक्टर विद माई स्टेपल। उन्होंने पहला स्टेपल लगाया कॉलर पे, उसके बाद सेकंड स्टेपल बॉडी पे लगाने के लिए जब वो जाने लगे तो लीवर स्लिप कर दिया, तो वो अपनी जगह से हट के वापस आके उन्होंने लीवर रिट्रैक्टर को टाइट करना था। इस दौरान उन्होंने अपने असिस्टेंट को कहा कि आप स्टेपल फायर करें। मैं OR में रहता हूँ हमेशा, मैंने माजरत की, मैंने कहा सर आई डोंट वांट यू टू फायर। डॉक्टर साहब नाराज हो गए, मेरे जिगरी दोस्त थे, जस्ट लीव द रूम शाहिद, you have insulted my assistant। मैं चला गया बाहर, रूम से बाहर आके मैं कॉफी रूम में बैठ गया, चाय पीने लगा। थोड़ी देर के बाद नर्स को देखा वो घूम रही है वार्ड में इधर उधर, क्या परेशानी पता चलो किस स्टेपल पे आ गए। उन्होंने फायर किया, इसकी वजह ये थी कि उन्होंने पहले ट्राई नहीं किया था, मैंने उनको, तो मेरा कहने का मतलब 12 मैं गया अंदर जाके, फिर जो भी करना कराना था हमने किया। मैंने उनको डॉक्टर साहब को इशारा किया, मैंने बताया ये कह रहा था तो इनको ट्रेन करो, अभी थोड़ी देर के बाद OR खत्म होता है तो इनको ट्रेन करो। तो सर ये सब महफिल जमाई इसी बात के लिए कि हम जब OR में जाएं तो हम पेशेंट इज आवर इंटरेस्ट। इट्स नॉट अबाउट दैट आई एम एम्बैरेस्ड इन फ्रंट ऑफ माय सर्जन, आई एम नॉट एम्बैरेस्ड अबाउट माय सेल्फ इन फ्रंट ऑफ माय सर्जन। मी एंड माय सर्जन वी आर वन, वी आर फिंगर्स, टू फिंगर्स, वी कैन नॉट बी सेपरेट। एम्बैरेसिंग ये है कि हम पेशेंट को, बेचारे को उस हालत में ना भेजें जिस हालत में वो नहीं आया, हम कुछ और करके भेज दें उसको, बेचारे को तकलीफ और पे। तो दैट्स द पॉइंट। ये अब हम करेंगे वहां पे, ये 2 स्टेशन हमने लगाए, ये लैप्रोस्कोपिक स्टेशन है और उस डिवाइसेस के अंदर हम कुछ ऑर्गन रख के कुछ आप लोगों को स्टेपलर देंगे। अगर मेरे दोस्तों ने मेरे साथ ताउन किया, हम साइड टू साइड एनास्टोमोसिस करेंगे। एक में एक उसमें एंटेरोस्टोमी क्रिएट करना, आप लोग 2 एंटेरोस्टोमी क्रिएट करना आपने हर ऑर्गन में। एक में आप एनुअल इंसर्ट करना, एक में आप कार्टिलेज इंसर्ट करना, फिर आप फायर करना, ठीक है। ये लैप्रोस्कोपिक है और ये हमारा ओपन का स्टेपलर है। यहाँ पे हम आपको इसकी हैंड देंगे, सारी फिगर्स वगैरह बताएंगे जो भी हो सकता है। तो आई एम पासिंग ऑन टू डॉक्टर रबिया टू टेक ओवर एंड एक्सप्लेन कि आगे लोगों ने कहाँ जाना है, कैसे जाना है। Thank you very much. If anybody have any question, please tell me. Thank you. All the best.
Guys, आप लोग 4 groups में थे ना divided double, तो group में share किया था, accordingly एक हो जाए।
Before concluding our session, I would like to invite on stage the man behind the entire vision and the co-host of COLOCON 2022, Dr. Khurshid Ahmed Samo.
इससे ज़्यादा आपको नहीं थका सकते. Thank you so much for giving that much of time. We thought that maybe the lunch makes you drowsy and the third session may not be that attentive. This is what we have been seeing post-lunch syndrome जो है ना, it's a graveyard session. So graveyard session से बचने के लिए हमने कहा ये थोड़ा सा stretch कर लेते हैं, ये session करने के बाद lunch serve करते हैं. So I will not come between you and your lunches. I thank you for your participation and interest, and I hope that it was useful. And we'll keep doing inshallah these workshops over next colocons as many as we can. और आपको हम हमेशा दावा देते रहेंगे. Please keep coming. Thank you so much. Thank you.
My heartfelt gratitude to all of you for being here with us today. I'm sure that you had a delightful learning experience. Before we depart, it is my pleasure to invite you for lunch. Thank you and Allah Hafiz.
So while we are here, I was forgetting the most important thing, which is thanking the helping hands. I am thankful to Mr. Shahid, who has come all the way from Dubai, and he had the greatest input in organizing these workshops today and tomorrow's, and the industry. Mr. Arsalan from Royal Medical, thank you, Arsalan, and Mr. Majid Hussaini from Biophysic. Is that right name? I took Biophysic. Thank you, Majid Saab. Thank you, Arsalan Saab. बहुत बहुत शुक्रिया.